Thank you, Rahul, and good evening, all. So I will be the coordinator for the Hall B, and I thank you all on the behalf of Dr. Sachin Gupta, and thank you for your kind presence and sparing a valuable time in the Saturday evening. So today's topic, today's session is divided into two parts. First is a hematological malignancy, and second one is the head and neck. So it's my honor and to pleasure to invite Dr. Pawan Kumar Singh, uh, who is our old friend and our senior, and sir is head of the department in clinical hematology and BMT chief at Artemis Hospital, Gurugram. Sir will be starting his topic. So how do I treat CLL in 2022? Dr. Pawan, sir, over to you.
Hello. Yeah, am I audible? Yes.
Yes, you are audible. You can put your microphone little nearer.
Okay.
Yes.
So first of all, I would like to thank Dr. Sachin Gupta for inviting me for this wonderful meeting which he has organized, and I would like to thank Dr. Deepak Singla, who is chairing this session. So the topic which I've been given is recent management of CLL with the newer BTK inhibitors. So in recent past, if we see, the management of CLL has changed a lot, and especially in this COVID situation, hospitals, they want the treatment to be done at home, and because of this COVID. So in this scenario, the oral medicines in any type of illness is very important. So, and here with the FDA approval of BTK inhibitors and other drugs, so this had been made possible, and with availability of these drugs in India also, so we can offer this treatment which patient can take at home, and especially in COVID situation, and plus they are more effective also compared to chemoimmunotherapy. So next slide. So CLL, if we see, it's basically a chronic condition, and it requires basically long-term treatment, and so tolerability is very important. So any drug which we are planning to give in a patient of CLL, it should be tolerable, less side effects, and because we all know that CLL is incurable malignancy. So ultimately, it's the way by which how we can better control the disease. So the median age in this study, that is almost 72 years is the mean, and 90% of patients, they are diagnosed are more than 55 years of age. Usually because it's a disease of elderly people, so usually some kind of comorbid illness they usually have, and it is incurable disease, so it requires long-term treatment, and long-term follow-up also is very important. Next slide. Now the prognostic value of fish is very important in management of patients. So fish has to be repeated at diagnosis when we are planning to start treatment, because most of the time in CLL for rise stage 1 to 3, treatment is not indicated. Only for 3 and 4 stage we need treatment, and once we have decided to embark on the treatment, that time we have to do the fish, and at each time patient relapses, there also we have to repeat the fish, because the patient at relapse can acquire new cytogenetic abnormalities, and depending on that can change the management plan. So fish, we all know that this is the based on the incidence of abnormalities like deletion 13q. It is the most common abnormality, and if we see the prognosis wise, so deletion 13q has the best prognosis, and so is with the normal karyotype, and we all know that deletion 17p or TP53 abnormalities, they have the worst outcome, and the next worst is deletion 11q. So And in this Kaplan-Meier curve, we can see that the karyotype of 13q deletion has the best prognosis, and then after that is the normal karyotype or the 12q abnormal 11q deletion, and the worst is with 17p deletion. Next slide. We all know this has already been discussed. The TP53 has the worst prognosis. So, and TP53 mutation or deletion both have the worst prognosis as compared to those patients who are not having TP53 deletion. And similarly, with the IGHV mutation status, the mutated patients have better outcome as compared to the unmutated ones. Next slide. Now the NCCN guidelines. So if we see the current guidelines which have been published in 2022, so the patients who are more than 65 years of age or patient having less than 65 years with significant comorbidities and the creatinine clearance is less than 7%, this guideline they have mentioned is acalabrutinib plus minus obinutuzumab, or other options are ibrutinib or venetoclax plus obinutuzumab, and the other regimens are like bendamustine, chlorambucil plus obinutuzumab. So these are other various second line options which are available for those patients who are younger, fit, less than 65 years of age without significant comorbidity. Still, the preferred regimen is acalabrutinib plus obinutuzumab or ibrutinib or venetoclax plus obinutuzumab. Here, the important thing which is to be noted is except with the combination of obinutuzumab, the mostly these are oral drugs, and now we can see that the FCR has been put into, or the other chemoimmunotherapy they have put it into as a second line option. Now, Bruton tyrosine kinase inhibitors, the overview of that. So, what is BTK? So basically, it is a non-receptor protein tyrosine kinase, and it is a member of TEC family of kinases, and it is expressed on all hematopoietic cells except T cells, and predominantly expressed on B cells. And it is important in BCR maturation and BCR signaling, and so it is important for BCR, B cell development, differentiation, signaling, proliferation, and survival. So if we inhibit BTK, so it is a therapeutic, it has therapeutic potential, and that is why it was made. Uh, so that is how if this drug is effective in management of CLL. Next slide. So these are the various types of BTK inhibitors. One is the covalent irreversible BTK inhibitor. Other one is the non-covalent, that is the reversible. So non-covalent is pitobrutinib, and the covalent irreversible BTK inhibitors are first generation is ibrutinib, and second generation is acalabrutinib and zanubrutinib. So we have in India except zanubrutinib and pirtobrutinib. So the other ibrutinib and acalabrutinib are available in India. Next slide. So if you see in all these trials, these are landmark 24-month PFS analysis for use of BTK inhibitor as a first-line treatment in CLL, in Illuminate trial, as Alliance trial, and Illuminate trial. So in both of them, when ibrutinib was in the first Resonate, it was compared with the chlorambucil. Second Alliance trial, it was compared with BR, and second one is ibrutinib with obinutuzumab. It was compared with uh, obinutuzumab plus chlorambucil. So in all these studies, if we see, the PFS was better in ibrutinib and almost in the range of 80 to 90% when it was compared to the other regimens. Next slide. So this is the 5-year versus 12% in when it was compared with chlorambucil. And so in all these trials, it was more effective. And more important thing to note is it also this improvement or this better outcome in terms of PFS and OFS was seen in patients with deletion 17p or deletion 11q or IGHV unmutated. So in high risk CLL also, the better PFS and overall survival was seen. Next slide. Now, this is the first BTK inhibitor, ibrutinib. It is approved in the management of CLL, and it is a first generation specific irreversible uh, inhibitor of BTK and alternative irreversible targets. So the more important thing to note is that it has off-target effect also. So which is responsible for if it inhibits the BTK and TAG, so it causes the off-target effect on heart, that is the atrial fibrillation, and because of this they can have hemorrhages also. And if it also inhibits EGFR, and that causes rashes and diarrhea, arthralgia. So the unmet need was to have more selective BTK inhibitor to reduce these adverse effects related to the off-target effect of BTK inhibitors. Next slide. So these are, and in real world data in the clinical practice, if you see though it was more efficacious, but still the discontinuation rates were high, and it was in the range of 14 to 23% for patients who discontinued treatment because of the adverse effects, and almost 15 to 20% of patients required dose reduction again because of the adverse effect, mainly because of the off-target effect of the drug. Next slide. Now coming to the acalabrutinib. So this is a second generation BTK inhibitor which has less off-target effect, and that is why the adverse events are less when compared to ibrutinib. So it is a potent selective BTK inhibitor that minimizes off-target activity. In this diagram, we can see that it has minimal effect on TAG, other tyrosine kinases like TAG, EGFR, and ITK-mediated signaling, and that is how it. So we can see that these are the IC15 nanomolar concentration. We can see that the potency and selectivity of acalabrutinib and ibrutinib. So when comparative analysis was done, so it has less off-target effect on these other tyrosine kinases. Next slide. Now the PKPD data. So PKPD data were reported in this ACL-CL011 dose escalation study, and it has rapid oral absorption when dosed at 100 mg BID dose, and the mean plasma peak concentration are reached between 0.6 to 1.1 hours, and it has a short plasma mean half-life, and it is given as BID dose. Next slide. Next slide. So this is the now coming to the clinical trial. So Elevate T, and so this is the study design in which the drug was given opportunities. So one arm, it is a randomized phase 3 study, 1:1:1 ratio, in which acalabrutinib combined with obinutuzumab or alone versus obinutuzumab in patients. So in one group, obinutuzumab plus chlorambucil 6 cycles, other group of acalabrutinib plus obinutuzumab into 6 cycles, and the third group only acalabrutinib. And the outcome was measured. The primary endpoint was PFS, and the secondary endpoint was again PFS and overall response. Next slide. So this was so almost 170 patients were enrolled in each arm, and so basically most of the patient the discontinuation rates, completed regimens, almost everybody completed, and the discontinuation rates was almost 25%, 20 to 30% of patients. Next slide. Now this is important to note in this slide. So we can see that the PFS, so this is very important. So when it is compared acalabrutinib plus obinutuzumab, the PFS at 40 months, 48 months almost. So it was 87, almost 87% for acalabrutinib plus obinutuzumab, And in acalabrutinib alone, it was also significant, and it was 78%. So here we can see that it's very important when it was compared obinutuzumab with obinutuzumab plus chlorambucil, the PFS was much better in acalabrutinib alone or acalabrutinib plus obinutuzumab arm. Next slide. And again, so in the subgroup analysis, if you see compared when subgroup analysis was compared with respect to the age, so almost similar kind of response rate in patients who are less than 65 or more than 65 years of age. Then between the sex difference, rise stage, ECOG performance score. Next slide. Then again, bulky disease, and irrespective of the mutational status or a high risk cytogenetics, the response rates were comparable in both the arms. Next slide. Now, this is again the overall response rate was. So here also in acalabrutinib plus. So the more important thing to note here is in the purple thing, we can regard the CR, the complete remission rates were more in acalabrutinib plus obinutuzumab. It's in the range of 30% as compared to 11% in acalabrutinib. So when acalabrutinib is combined with obinutuzumab, it is much better, and we can have better overall response rate, and also we have better complete response rate in terms of bone marrow disease. The median overall survival not reached in any arm till the completion of this study, and 48 months overall survival rates were higher in acalabrutinib plus obinutuzumab arm, almost in the range of 93%. Next slide. Safety, again, this is of clinical interest. So overall events of clinical interest, including cardiovascular events, was similar in both acalabrutinib arms and consistent with previous interim analysis. Next slide. So the most common adverse events occurring in more than 25% of patients, it was diarrhea, headache, neutropenia, fatigue, and all these. Next slide. Next slide. Yeah, so the bruising and hemorrhages, these are more common with the ibrutinib because of the off-target effects. Again, atrial fibrillation and cardiac arrhythmias, they are more common in ibrutinib, and hypertension also. So acalabrutinib, all these adverse events were less in acalabrutinib group. Next slide. Now, this is again a very important study when acalabrutinib was compared with the other drugs, that is idelalisib plus rituximab or bendamustine plus rituximab. So again, it is a randomized multi-center trial in relapse refractory. So those was in newly diagnosed, and this is in relapse refractory CLL patients. Again, the primary endpoint was PFS, and the secondary endpoint were overall survival and safety. Next slide. So here also we can see that the overall response rate with acalabrutinib and idelalisib, when it was compared with idelalisib plus rituximab or bendamustine plus rituximab. So the overall response rate was almost comparable in both the group. Next slide. So here the important thing is the PFS, in acalabrutinib, the median PFS was 63% as compared to 20% in idelalisib plus rituximab or bendamustine plus rituximab. And similarly, the progression-free survival. So here we can see that the median time on study was 36 months and 35 months, almost comparable in both the group. So the PFS is better in acalabrutinib when it was compared to idelalisib plus rituximab or bendamustine plus. Again, PFS when it was studied with respect to the deletion 17p or IGHV mutational status. So the PFS in patient with high risk. So the similar kind of results were also achieved in those patients who are having higher risk cytogenetics or IGHV mutation status. Next slide. So in subgroup analysis also, and with acalabrutinib, when was compared to idelalisib plus rituximab or bendamustine plus rituximab, there was in subgroup analysis also acalabrutinib, the better response rate and better PFS was observed in acalabrutinib arm. Next slide. Overall survival. Next slide. Again, as same trial, Ascent 3-year follow-up, safety overview. So safety, 5% of patients in any group included. So pneumonia, diarrhea, and fever. So slightly more in acalabrutinib arm as compared to bendamustine plus rituximab arm or idelalisib plus rituximab. Next slide. I'll just skip this slide. Next slide. Again, here also we see that atrial fibrillation, hemorrhages, another target. They're all also acceptable toxicity. Next slide. Now this is important study in which acalabrutinib in ibrutinib intolerant patient. So acalabrutinib was given as 100 mg BID dose, and the primary endpoint is overall response rate. So basically, patients who are received more than one prior line of therapy and not appropriate for treatment or retreatment with urine analogs, and they were intolerant to ibrutinib or discontinued ibrutinib due to persistent grade 3-4 adverse events or grade 2 adverse event related to ibrutinib that persisted for more than 2 weeks. So these were the patients which were included in this study. Next slide. So in those patients who were intolerant to ibrutinib, when acalabrutinib was given, the PFS, the overall response rate was in the range of 72%, and with the 5% CR rates, the overall response rate it included almost 77%. Next slide. And again, in secured trial, the results of phase 3 randomized study of zanubrutinib versus BR. Another here also the PFS was better. And with the IGHV mutation status, high risk cytogenetics. So there also the zanubrutinib has, when it was compared to BR, the better, it is better in terms of PFS and IGHV high risk mutational status also, though the overall survival was comparable between the two groups. Next slide. Sorry, I think some it got disconnected. Yes.
Yes,
So then
Dr.
again, so now we can see that the NCCN updated guidelines. So now the preferred regimens are acalabrutinib, and so most of the regimens, the first line treatment here we can see that is the oral therapies, whether it is acalabrutinib, ibrutinib, venetoclax, or zanubrutinib. So plus minus obinutuzumab. Now the FCR, the chemoimmunotherapy. So this is the paradigm shift which we are seeing both in elderly unfit patients and younger fit patients. So here the chemoimmunotherapy is being uh, made as the second line option as compared to the oral therapies. So with the oral therapies, they are more efficacious, better. Uh, Tolerability is also better, and easy to use. Patient can take at home. So when it is compared with chemoimmunotherapy, obviously it is better as compared to chemoimmunotherapy. Next slide. Next slide.
Chabidi.
Okay, so this is the paradigm shift which I am talking about. The chemoimmunotherapy, the goal of therapy is disease eradication. But the only disadvantage of this oral BTK inhibitors or other oral drugs is that they have to be continued for lifelong and almost till the progression of the disease. So this is the disadvantage, and it is not finite therapy compared to chemoimmunotherapy, which has a finite therapy given for a fixed duration. So this is the disadvantage, and but the if we see the other advantages, like it is effective in terms of better efficacy and in in even in patients with high risk cytogenetics or unmutated status IGHV, high risk with unmutated IGHV status also. So with this, I would like to end my presentation here. Thank you. So if any questions, most welcome. I
Dr.
think
Deepak sir, you are on mute. Please unmute yourself.
Okay. Thank you, Dr. Pawan Kumar Singh, and for giving this crisp updates on CLL 2022. And sir, I do have one question. Have you ever used acalabrutinib, and how do you select those patients specifically?
acalabrutinib we have used in 2 or 3 patients we have used, and it is yes, it is efficacious and side effect profile. If we have seen patients on ibrutinib developing bleeding complications, sometimes hypertension, so those off-target effects are less, and so in that way we can see that yes, acalabrutinib is better option.
Okay.
But the only disadvantage is the cost, and but now we have the generic also available. I have not used the generic one till now because it was approved recently only last month. So we
Okay.
have generic ibrutinib also available, but obviously that will take to build confidence on generic acalabrutinib will take some time unless we start using it. But I had the original molecule that Calquence we have used in 3 patients, and so far they were doing good and having good response, good control over the disease.
Okay. Right. Okay. Apart from intolerance to ibrutinib, any other indication where you would prefer acalabrutinib
See,
apart from?
yeah, in high risk, basically, if you see there is no head-to-head comparison between acalabrutinib and ibrutinib. So this is
Mm-hmm.
there is no head-to-head comparison between ibrutinib and acalabrutinib. So
Okay.
efficacy-wise, you cannot see. But yes, if we see the high-risk disease status, so both ibrutinib and acalabrutinib works in high-risk disease, whether it is high-risk cytogenetics or unmutated IGHV status. So when it is so if we have data of comparison between ibrutinib and acalabrutinib, then we can see about the efficacy. But safety wise, yes, safety wise, because in that study one where the patients discontinued ibrutinib, and in those patients when acalabrutinib was used, they had they were better. It was better tolerated, and so tolerability was better in acalabrutinib.
And so majority of the patient, they tolerate the standard dose, whatever the standard dose is there?
Yes,
or
standard 100 mg BID dose. That is the standard dose, and they tolerate it.
100 mg TID.
100 mg BD twice daily.
Twice daily, right. And any issue with hepatic impairment or renal impairment? Any dose modification with that?
No, I don't think there is any dose modification is there.
Okay. Thank you, Dr. Pawan Kumar Singh, and thank you for sparing your valuable time from your busy schedule, and we are very much thankful to you. Over to you, Rahul.
Thank you.
Now, can we move on to second second panel, Rahul? Professor Malhotra is there?
Yes, sir. We can move.
We can move to second session. Right? Rahul?
Yes, sir.
Actually, Dr. Arihant wanted to shift prepone his time from 7:30 to 6:30. I mean, is that true? I mean, can we?
So Pooja, can you respond?
Because his session was scheduled on 7:25 to 7:45, but I saw the one message in the box that he wants to prepone his message that on 6:30. Just confirm it, please, because this second session is.
I think second session is panel discussion, sir.
Yes, yes, I know that it is because half an hour session. It is a half an hour session. So can you confirm?
Yeah, yes, sir. Just give me a minute.
Okay, because we are already running late by 5 minutes. Please confirm it fast before that. And good evening, sir. Dr. Professor Malhotra. Good evening, sir.
Good evening, Dr. Deepak. How are you?
I'm fine, sir. Thank you. Okay, everybody's there. I think Dr. Vishnu is there, and Dr. Akhilesh Pandey, and Dr. Anubha is also joined. Can we start with your panel discussion, sir?
Yeah, sure.
Please, over to you, sir. Professor Malhotra, please.
Okay. Thank you, Dr. Deepak and Dr. Sachin for giving me this opportunity for this panel discussion. So the panel discussion is on how do I treat multiple relapsed refractory multiple myeloma. Yes. And the panelists are Dr. Upendra Sharma, who is Senior Consultant Hematologist at Bhagwan Mahavir Cancer Center, Jaipur. Dr. Sandeep Juseja, who is Medical Superintendent and a good friend of mine. He's also HOD, Department of Medical Oncology, SMS Hospital. Dr. Ranjit Kumar, CS, Senior Consultant Medical Oncology at American Oncology Institute, Hyderabad. Dr. Narendra Agarwal, Senior Consultant, Department of Hematology, Oncology and Bone Marrow Transplant at Rajiv Gandhi. Dr. Vishnu Sharma, Consultant, Department of Hematology at SMS Jaipur. And Dr. Suvir, Consultant Hematologist Oncologist at American Oncology Institute, Ludhiana. I saw Dr. Sandeep Juseja and Dr. Vishnu Sharma. Can you confirm whether all the panelists are there or not?
I think Dr. Akhilesh Pandey is there. Dr. Anubha is Ekta.
Yes, sir.
Can you confirm whether all the panelists are there or who is there? Just can you confirm that?
Pooja, are you there?
Yes, sir. Pooja is there. Yeah, Pooja, please respond.
Rahul?
Yes, sir. Pooja is responding.
We are able to hear you. So Pooja is responding.
Yeah,
Hello, sir. Dr. Jasuja sir has joined us. Dr. Vishnu Sharma is there in the call.
we can see that Dr. Vishnu Sharma is, I think he's available. And
So can we request all the panelists to switch on their videos?
Yes, please. Because most 2 or 3
Yes.
names are not visible by this. No?
So we
Pankaj sir,
request all the panelists to switch on the videos.
Pankaj sir, very good evening. How are you, sir?
Good evening, Dr. Sandeep. How are you?
After a long, we fine, sir. How are you and everywhere?
Yeah.
After a long time, we are meeting, sir.
Yeah, virtual meeting.
Sir, hope very soon we will meet by face and in July, and I'm trying to have a meeting at Jaipur.
Okay, great.
And just please save your dates also, sir. 29 to 30 July.
That's great. So what I think we can start with these two people, and then as people join, then we can just put it in the chat box and we can continue, because
Yes,
otherwise we'll get delayed.
I will update you because
Yeah.
they all will join in 2 or 3 minutes.
Yeah.
We can start the panel now.
So
Vishnu
okay.
Sharma is there. Dr. Vishnu Sharma.
Yeah.
is
So Dr. Vishnu and Dr. Sandeep Juseja, and and we can, it's just a discussion only on relapsed myeloma. So Dr. Vishnu and Dr. Sandeep, what I have done is I have taken 3 case scenarios of relapsed myeloma. The first is relapse post-transplant, which again, is a quite common thing. So this guy is a 50 years old gentleman who is multiple myeloma, IgG kappa. At the time of diagnosis, he had anemia and bone lesions, and he had RISS 3 risk stratification. That was he has FISH T414 translocation. So he was given standard induction therapy with VRD. He received 6 cycles, and then he was transplanted with melphalan 200 milligram per meter square. And then post transplant, he was put on maintenance therapy with lenalidomide 10 milligram for 21 days out of 28 days. And then he was doing fine till a year and a half post transplant, when it was noted that he had increase in the kappa light chains on a routine checkup. And the kappa lambda ratio was 3.5 as opposed to 1.65, which is the upper limit. So there was increase in the kappa chain. Now he's asymptomatic, he's otherwise doing fine. So that means there is a biochemical relapse in this patient. So how would you proceed in this patient who has asymptomatic increase in the kappa light chain? So I can start with Dr. Vishnu Sharma first.
Yes, sir. Good evening, sir.
Good evening.
So he is basically high risk myeloma with translocation 414, but still he is asymptomatic. So this is indolent biochemical relapse. So I would like to repeat the free light chains after 1 month and continue with standard maintenance.
Okay, so because it is simple biochemical relapse, so you would like to wait and watch because he does not have any CREB features.
Yes,
Dr. Sandeep?
Yes, sir. Actually, I do agree with Dr. Vishnu, but somehow sooner or later he might relapse because of high risk, because he has high risk cytogenetics before transplantation, and it's rising. No doubt, we will wait for 1 month and we will do the test again. But somehow, if it is again rising, then we have to plan to change the treatment, because it will shortly relapse immediately because of high risk.
Okay, so what I can gather is that you have to keep your antennas up because it's a high risk disease. So, I mean, just in in some short period of time, he's going to relapse. So Dr. Upender Sharma has also joined. Welcome, Dr. Upendra. Dr. Upender. So this patient, have you listened to the history or?
Sir, sorry, I joined late. So can you repeat questions, sir?
Okay, so this patient, we are talking about a relapse patient. So this is a 50 years gentleman who has IgG kappa disease at the time of diagnosis, RISS 3, FISH was 414, He received VRD 6 cycles and he was transplanted with melphalan conditioning, standard melphalan conditioning, 200 milligram per meter square. And he was on maintenance therapy with lenalidomide. And at a year and a half, 1.5 years after the transplant, he had asymptomatic increase in the kappa chains. So we were discussing what would you do? You have a follow-up of this patient. So asymptomatic rise in kappa light chain.
So now, what was the rise? Whether the patient has doubled this kappa light chain?
Yeah.
So now patient is having a biochemical relapse, and transplant is within 2 years he has relapsed within transplantation. So not a very good disease. So patient is already having high risk molecular marker, and now behaving with this clinical scenario, his patient is behaving as in a high risk manner. So we have to change the regime. He had received initially VRD and then transplant and lenalidomide. So a second line medicine with say either daratumumab.
Okay, so right now, so basically what I can gather is that you would not like to now wait too long, and you would like to initiate induction therapy again.
So we can see this patient. He has this biochemical relapse, and the kappa change is now the ratio is 3.5.
Yeah.
And the doubling of the kappa, this change from the baseline. What now patient is having doubling of this kappa change. So now patient will sooner or later will have a frank relapse of the disease and will have clinical manifestations of the disease. So on 10 milligram of lenalidomide and with 3 months of 3 or 4 months of transplantation, so patient will be having a very aggressive relapse now. So we'll not wait for the clinical manifestations to develop for this patient, and we have to treat very aggressively this patient. Having a baseline 414 translocation is a high risk, and now patient is clinically behaving in a very in an aggressive manner. So we have to deal with this patient in a very aggressive manner, sir.
Right. So you all, all right. So Dr. Vishnu Sharma also said the same thing. Dr. Sandeep also said the same thing, that, you all agree that it's a high risk disease. And even though it is a asymptomatic rise in light chains, but since it has happened within 2 years of transplant, so you would like to, initiate the patient on treatment either sooner, or maybe, at 1 month you would repeat the light chains, and if they are still increasing,
yes,
so
that is not a matter, sir. Within some 1 month we can see whether this is a real, not a laboratory error, real rise in the change. Then we have to definitely change to our therapy of this patient.
Right. So this is what you have discussed: high risk at diagnosis, biochemical relapse, and 18 months post transplant. So another question is whether you would initiate the treatment, or would you like to do any other workup like bone marrow examination or a PET CT scan or so in this patient? So I can start with Dr. Vishnu Sharma.
Sir, I would like to repeat bone marrow aspiration biopsy, cytogenetics, and FISH panel.
Okay.
And if patient is affordable, then we can repeat PET scan also. Okay. But at least cytogenetics and FISH should be repeated.
You would like to do that. Okay. Dr. Sandeep?
So same thing, we will reevaluate complete, we will do reworkup completely for this patient, and PET scan is free of course now for Rajasthan patient. There is no cost issue for us.
Okay. So you are at advantage, in Rajasthan. Right. So you all agree that you would like to initiate the treatment, and you would like to do at least a bone marrow examination and repeat cytogenetics, at least look at whether this patient has acquired P53 or a very high risk cytogenetics or not, and then you start. So now we come to the treatment option. So
for most of the time, this myeloma patient, myeloma is an incurable disorder. Most of them, these patients, they have tendency for relapse, and it is very difficult for us patients to counsel for a repeat bone marrow aspiration biopsy. So most of the patients, they are very adamant, they don't go for this bone marrow examination. It is a real challenge.
So you are absolutely right. So the only, I would say that, when you are doing a repeat bone marrow at relapse, is that looking at P53, because if it is P53, your treatment may or may not change, but the prognosis will definitely change dramatically. So that's the only thing. But I totally agree with you that bone marrow is a painful procedure, and many patients do not agree for bone marrow, and many times there are biochemical relapse, and this is the question which the patient asks. There is already a relapse, and sir, why do you want a bone marrow? So bone marrow, I think we only require for fish cytogenetics. Otherwise, I don't think so. You will get any more information from the bone marrow, except in rare circumstances, you may see plasmablast or looking at high risk morphology, high risk morphology of plasma cells. Okay, so now we come to the treatment options. So we have options like Dara Botidexa, Dara Lendexa, Carfil Pomdexa, Boti Lendexa, any other regimen. So I can start with Dr. Vishnu.
So it depends on patient's affordability. If patient is affordable, then Dara-based therapy would be the best option.
Right.
So I would like to choose Dara bortezomib dexamethasone if patient is affordable. If patient is not affordable, then carfilzomib, pomalidomide, dexamethasone is also a good option.
Okay. Dr. Sandeep, what is free in Rajasthan? Dara is free?
Sir, sooner we will get free of cost Dara to the patients within 3-4 months, because now patients
we will send all our patients to you. Okay.
Sir, in the patient, I would like to reevaluate the patient for neuropathy and previous treatment residua. If the patient have neuropathy and have a symptom, then I would not use the botulinum and Dara-Lendexa is best for this patient. And if the patient is good in shape, then we can go for Dara-Botidexa. But yes, Botulinum-Lendexa is also very reasonable option in this patient, because after 6 months we can reuse this and with very good results.
Okay. And Dr. Upender?
So yes, sir, I agree with Dr. Desuja. So we have to see what is the how patient is tolerated previous therapy, whether there is any pre-existing neuropathy, what is the patient cardiac status, so and affordability of the patient. So all the things are all right. Patient is affordable. Yes, Dr. Vishnu, I will go for Dara, bortezomib, and dexamethasone. If affordability is a question, then if cardiac status is good, carfilzomib Pomdexa is a good option for this patient. But preferably, I will go for Dara, Boti, and Dexa for this patient.
Right. So I think the message is clear to the fellows and listeners who are listening to this talk, that you would look at the previous side effects of the therapy, and based on the comorbidities, cardiac comorbidities and neuropathy, you will take a decision. And if the patient can afford, you would like to give a Dara-based regimen in these patients. All right, we go to the case 2, and he is a 75 years old gentleman who had IgG lambda disease. Baseline, he had anemia, bone lesion, and hypercalcemia. He was ISS1, RISS1, and FISH 1Q amplification. 1Q amplification these days now has been put as a high risk now. Just 3 days back or 4 days back, the article has appeared. So he received doublet Lendexa for 18 months because of the age factor, and the M band never became 0. It remained stable at 0.2 gram per deciliter. And after 1.5 years, since the M band was stable, so he was put on Len maintenance 10 milligram for 21 days in a month. So Lendexa followed by Len maintenance. Now, 1 year after Len maintenance, there is a gradual increase in M band from 0.2 to 1.5 gram. Again, there is no CRAB. So again, in indolent biochemical relapse in a transplant ineligible patient who has received doublet. So what would you do, Dr. Vishnu?
Sir, he also falls in the category of high risk because of 1Q gain. And his the ambient has increased from 0.2 to 1.5 grams. So it is more than 1 gram increment.
Right.
So ultimately, he will also require treatment. So I would like to start treatment with, I think.
Okay, we'll come to the treatment. So any difference of opinion, Dr. Sandeep Juseja or Dr. Upender, that this patient requires treatment, or would you like to wait?
No, I'm totally agree with Dr. Vishnu that we should treat, but in a patient, this kind of 75-year-old male, issue is what we are going to offer later. So
we'll come to that. We will come to that.
Yes,
so you also agree. And Dr. Upendra? Okay, so you all agree that you would like to do workup and you would like to treat this patient. So treatment options in this patient, these are some of the treatment options, but you can suggest your treatment option also. So Dr. Vishnu.
Sir, as previously described, it depends on performance status, cardiac status. So I think bortezomib, daratumumab, dexamethasone is best option for him. Or we can use, if patient is not affordable, then we can use pomalidomide, dexamethasone, or bortezomib, dexamethasone is also an option for him.
Okay, Dr. Sandeep.
So, sir, he already responding very well to Landexa 2 doublet for 18 months, and still he's 75-year-old male, and I would little bit afraid to use this all combination 3 combination therapy. Still, a Pomdexa is reasonable option for this patient, in my point of view, to take further.
Okay.
Later on, we will discuss.
Right. Dr. Upendra.
So, we have to see what is the performance status of this patient. So initially he has received doublet, and if patient performance status is say not too much frail, I will go with say only Dara Dexa combination, duet of Dara Dexa if affordable is not an issue, or if you can combine Dara Boti Dexa, then that is a good option. But you have to see how patient can tolerate. So initially we can start with Dara Dexa, then we can gradually escalate our therapy with adding a third agent with say pomalidomide or this what is in our treatment armamentarium.
Right, fair enough that he's elderly, so we really want to see that he should not develop toxicity because of the therapy. He has done reasonably well for year and a half, so that's a fair choice to start initially with Dara Dexa and then add bortezomib or POM or cyclophosphamide depending upon the situation. Dr. Ranjit has also joined. Welcome, Dr. Ranjit. So whether have you listen to the case presentation? Otherwise, we have another case coming up.
Yes, sir. Thank you very much, sir. So this gentleman is a little elderly gentleman who was received two doublet upfront, now having biochemical relapse. So based upon whatever the data which is available, depending upon now again we need to see his performance status and his comorbidities. So probably I would choose Dara based at this point of time, or if financially if it's not a problem, I will use the Dara based. Otherwise, I go for the pomalidomide dexamethasone.
Right. So I think fair enough. So there is a consensus among the panelists that based on the affordability and based on the comorbidities and other things, you would choose Dara based if patient is affordable. Otherwise, POM Dexa or cyclopom Dexa are good enough. So we have another 5 minutes. So we go to the third case, which is truly relapsed refractory, and let's discuss about this two relapsed refractory patient who is a 56 years old gentleman. He had multiple myeloma, IgA kappa, all the CRAF features, RISS3, creatinine 3.2 milligram at the time of diagnosis. He had T1114 at the time of diagnosis. So he received VCD 6 cycles because of the creatinine 3.2, Len was not given. And he received transplant with melphalan 160 milligram per meter square after 6 cycles of VCD. At day 100, he was in stringent complete remission and MRD negative status. And he was put on maintenance bortezomib twice monthly because the creatinine did not become normal. So creatinine remained at 3 milligram. 1 year post-transplant, his hemoglobin gone down to 7.8 and there was increase in the kappa light chains. So he was on erythropoietin. In spite of erythropoietin, his hemoglobin gone down and there was increase in the kappa light chain. And he was diagnosed with the clinical relapse at 1 year. Because of the clinical relapse at 1 year, he received Dara-based regimen, daratumumab, carfilzomib, and dexamethasone for 6 cycles. His hemoglobin came to 12 gram and normalization of light chain. So he achieved a stringent CR again. And he was continue with daratumumab and carfilzomib for another 6 cycles. So 1 year total. But after 1 year of Dara Carfil, there was an increase in the light chains again. And because of the increase in the light chains, now he received cyclophosphamide, POM, and DEXA regimen. Okay. So the light chains remained stable during the 6 months of therapy. But again, after 6 months, there was a doubling of kappa light chains. And now he was given melphalan, prednisolone, and thalidomide. So he has received lenalidomide, he has received pomalidomide, now he has received thalidomide. He has received bortezomib, he has received carfilzomib, he has received daratumumab. However, the light chains with melphalan, prednisolone, thalidomide continued to increase, and there was development of anemia, and serum creatinine was 3.5. So now we discuss the options in this patient. I'm just giving you, options. So maybe, I can have opinion starting from Dr. Vishnu Sharma.
Sir, again, it depends on side effects with previous therapy and affordability of patients. So venetoclax is definitely an option because he had 11-14 translocation. It can be explored. If patient is not affordable, then bendamustine is an option. And I don't have any idea about selinexor, whether it is available in India or not. But this is also an option in patients who has received exhausted all the available therapies. So selinexor can also be used. So all the
besides this, any other option if you have in your mind, so that you can also discuss.
VTD pace, but he is relatively young, 56-year-old male.
Yeah.
So VTD pace kind of regimen we can use, and we can offer second transplant if stem cells are mobilizable. So we can explore this.
Right. Dr. Sandeep, Rajasthan, what is available?
So, sir, already he's received more than 3 lines of therapy, and 11-14 is available. Then venetoclax is definitely venetoclax plus DEXA is the reasonable option for this patient and should be used in this patient if available and financial toxicity is not there. And secondly, now we have clinical trial belantamab mofitin, and we can use this after 3 cycles of refractory, and this is also reasonable choice, and Selexinor is not available. But somehow we are also conducting this trial of bendotin mofitin, and we can offer this patient upfrontly for this drug. And another drugs are what we can use is, if patient is highly affordable, then go for this to the USA for CAR T cell therapy. Yes.
Okay. All right, Dr. Upendra.
Really good case. You have exhausted all our weapons to treat our patient. So yes, bendamustine is an option. So bendamustine, pomalidomide, dexamethasone can be used. Bendamustine, bortezomib, dexamethasone, that can be received. We can go for liposomal doxorubicin, bortezomib, dexamethasone, that is a regime. Venetoclax, yes. Now, so we have accessibility of venetoclax, so that can be used for this patient. I am not not of experience with selinexor. So all of these are options. We have very limited options to treat this patient. And once these options are further gone, then we don't have much to offer to this patient. Yes, CAR T cell therapy is option, not presently available in India, but in Western world, yes, that is a good option for this patient.
Right. Okay. Dr. Ranjit, any difference of opinion or anything you want to add?
No, sir. Actually, he is ideal candidate because the definition-wise is a relapsed refractory. One is Benda, DEXA is venetoclax, or else like CAR T is another option. So same thing.
Right. So yeah, I think this is a truly relapsed refractory, more than 3 lines of therapy, and truly high risk disease. So if the patient is young and VTD pace is one option, CAR T, outside India, and Selenoxer trial initially was there, but right now, it is not available, even though we have compassionate use, but now they have also stopped giving on compassionate basis also. So just a quick opinion, anybody for palliation, just palliation, this patient, let's say, cannot afford venetoclax, Selenoxer is not available. So only palliative therapy.
So, sir, patient has gone through that much of therapy. So we can just give trial for bendamustine, that combinations or liposomal doxorubicin, we can buy a few months for this patient, and then else we have palliation only.
Sir,
Right.
what we
Yeah.
are using in past is VAD combination. We are also just forgetting the VAD combination. We can give for palliation to VAD in this patient.
Yeah, adriamycin is one. That's why I mentioned adriamycin. Vincristine is very weak, and dexamethasone obviously when you are giving this.
Yes.
Right. I think so. That was my last slide, and we have finished our time also. So thank you so much, all the panelists, for joining with me for this panel discussion. And more important than that is to see you all, virtually. And we thank the organizers also for giving us the opportunity to, discuss about myeloma. So thank you so much, and I hand over back to the organizers. Thank you.
Thank you, sir.
Thank you, sir.
Thank you, everyone. Thank you, panelists and the moderator. And is Dr. Deepak Singla is there?
I am there. Yes.
Okay, sir.
Okay. Yeah. Are we done, sir?
Yes, sir. So we can move forward to the next panel.
Yeah. Thank you, Professor Malhotra, for this wonderful session. Now our next topic is lymphoma, DLBCL. How do I treat a double hit and triple hit high risk, high grade DLBCL? For this, to moderate this session, I would like to invite Dr. Meet Kumar, who is a consultant hematologist, hemato-oncologist, and BMT physician at Fortis FMRI Gurugram. Dr. Meet, please. Dr. Meet, good evening. Dr. Singla this side.
Good evening, sir. How are you?
I'm fine, Meet. How are you?
I'm perfectly fine, sir. Thank you so much.
Yeah. Thank you for joining. I think your panelists are there already.
Yes, I am ready. My esteemed panelist will be there.
Okay, Dr. Sanjeev is there.
Yeah. Hello. Hi, Dr. Deepak. Yeah.
Yeah. Hello. Good evening, sir. Yes, Dr. Meet, you can start. I think we are
Okay,
already.
sure, sir.
Okay.
So I think I'll request the organizers to share my slides from their end.
Okay.
So are the slides visible?
Yes, sir.
Hello.
Dr. Meet, yes, sir, you can start, please. Yes.
Okay. So thank you so much. So I'll go straight the next slide, please. So I'm moderating this session on how do I treat double and triple hit lymphoma, and the high grade DLBC will come to what is the differences between the two. But yes, this is what we'll be discussing in the next couple of 20-25 minutes. So next slide, please. So first of all, I need to thank the chief moderator, Dr. Deepak, and of course the organizer for this meeting, Dr. Sachin Gupta, and of course the Horizon team for having conducted this wonderful meeting. Next slide, please. So these are my esteemed panelists who will be taking us through the journey of the difficult, so to say, difficult B-cell lymphomas, and what is their experiences and how do they deal with these type of bad diseases. Dr. Nivedita Dingra, is she there? Probably yes, she's there. She's a senior consultant in Max
Hi,
Super
Dr. Meet.
Specialty Hospital, Noida. Hello, Dr. Nivedita.
Hi, Dr. Meet.
How are you? All good. So then there PLK Hospital Dwarka, Dr. Ankur Mittal, a dear colleague from Mohan Dai Oswal Hospital Ludhiana. Are you there, Dr. Ankur? I think he's still to join. Dr. Sanjeev Yadav, who is going to be soon a German person, associate professor at Department of Hematology, SDPJ Lucknow. Dr. Sanjeev, are you there?
Yes, Dr. Meet, I am here.
Hello, Dr. Sanjeev. And lastly,
Yes,
Dr. Naveen Gupta. So lastly, Dr. Naveen Gupta, who is associate professor at Mahatma Gandhi Medical College and Hospital, Jaipur. So are you there, Dr. Naveen?
Okay,
So
so
I think
actually I have left BLK 8 months back. Right now I am in Venkateswara.
so. That is why I told Dr. Sanjeev. So you are my dear senior from BLK, but now at Venkateswara Hospital, Dwarka.
Yeah.
So
Okay.
so
Dr.
I'll move to the
Abhi
next
will be
slides.
joining
Next slide, please.
Hello, Dr. Meet, sir.
Sure. Okay, sure, Pooja. Thank you so much. Yeah. No issues, no issues. So this is the typical curve of diffuse large B-cell lymphoma, or that we can say aggressive B-cell lymphoma. During the years, the treatment evolution, the treatment improvisations, and the availability of newer and newer drugs has probably helped us evolve the treatment of diffuse large B-cell lymphoma. And that's the latest curve for the last couple of years that we have seen. And there's a constant improvement in the outcomes that we see with the treatment of B-cell lymphoma. Next slide, please. So today I'm not going to discuss about the B-cell lymphoma in general. What we will be focusing, we as a team of 4-5 people, hematologists, medical oncologists, will be focusing on the right aspect of the aggressive B-cell lymphomas. DLBCL, the standard DLBCLs we all treat, we all know for ages together. RCHOP is the standard way forward, and that is how we have been treating. But what about those 30% of the patients who have, so to speak, non-Burkitt lymphoma, non-DLBCL aggressive B-cell lymphoma? What are those lymphomas? So essentially, this is the spreadsheet of the aggressive B-cell lymphomas. If we leave apart the DLBCL, the high-grade B-cell lymphoma is a category of lymphoma that forms that has been recognized now by WHO 2017 as a distinct category that falls between DLBCL and the Burkitt lymphoma. These are, so to say, the aggressive part of the B-cell lymphoma, and they have been categorically called as high-grade B-cell lymphoma other than DLBCL. So in those high-grade B-cell lymphoma that constitutes almost 30% of the conventional DLBCL, in those DLBCLs, in those high-grade B-cell lymphomas, close to 10 to 12% patients may express what is called as CMYC and BCL2, and they would be henceforth labeled as double hit lymphoma or triple hit lymphoma when they are combined with BCL6 mutations as well. And the rest of those non-double hit and non-triple hit high-grade B-cell lymphomas will be called as high-grade B-cell lymphoma NOS. So they can be either of GCB or ABC type that we have been conventionally learned and teach about. Most of the high-grade lymphomas are germinal B center type, and that depends on whether they are NOS or double hit triple hit. That will depend on the expression or non-expression of a CMYC, BCL2, BCL6. So these once identify whether they are high-grade lymphomas, the treatment would depend further upon the IPI scores. We all do IPI scoring for all lymphomas in the clinical setting. But if they are low IPI score, they may be treated the conventional way. But the more and more data is now coming up that high IPI, high-grade lymphomas or aggressive B-cell lymphomas should be treated aggressively, and that is what should be the crux and the take-home message from today's panel discussion. The next slide, please. So this is the typical distribution of all the DLBCL, maybe close to 30% may be high-grade aggressive B-cell lymphomas. Of these B-cell lymphomas, maybe close to 12% patients may express double hit mutation or a triple hit mutation in the form of presence of what we call as CMYC mutation or BCL2 mutation or a BCL6 mutation on a FISH analysis. The meaning of those may be negative for these mutations. They would what we call as HGBL-NOS. And that's the high grade category that usually expresses the single hit mutation of CMYC. The next slide, please. So that's a conventional RIPA scoring that has used the parameters that we have discussed for ages. And the next slide, please. I'll go to the case 1 straight away. So the next slide. Yes. So this is a 53-year-old male who is a businessman by profession, who has no comorbidities and has presented with 3-month complaints of abdominal pain. Next slide. On examination, he has a palpable supraclavicular lymph node that's approximately 3 centimeter by 2 centimeter in the supraclavicular region, and a right axillary lymph node approximately 4 by 3 centimeter in size. His ultrasound abdomen had shown presence of multiple abdominal lymph nodes. The largest is measuring close to 3.8 by 3.2 centimeters. The PET scan that was done subsequently with the suspicion of lymphoma showed, next slide please, that was the PET scan slide, and that showed multiple lymph nodes at multiple sites, both above and below the diaphragm. The biopsy showed, yeah. The next slide. Yeah, so the biopsy axillary from the axilla was done, and that showed sheets of intermediate to large size atypical lymphoid cells with occasional blastoid appearing cells. So this is the catchy thing. So some of these cells had they were large cells, and they were blastoid appearing rather than conventional lymphoid appearing. So there was brisk mitosis, and including some atypical mitotic figures, and no tangible body macrophages were identified. On immunohistochemistry, the Ki67 was 65%, so it was above 50%. That is the usual cutoff for a high-grade lymphoma. The CD20 was positive as for B-cell lymphoma. In addition to that, CD10 and BCL6 were positive. MUM1 was negative, and CMYC was negative. So if we look at this data, high grade appearance of B-cell lymphoma, blastoid appearing cells, usually the germinal center origin because of the positivity of CD10 and BCL6, and it is not a double-hit lymphoma or a triple-hit lymphoma that should not be suspected because CMYC is negative. Next slide, please. So that's a composite diagnosis for this patient. High-grade B-cell lymphoma NOS, germinal center origin. The R-IPI, because of the increased LDH score of 2, was intermediate, and his CNS IPI was low. So my questions for panelists the next slide, please. The next slide. Yeah. So how do we in clinical practice, how do we differentiate between diffuse large B-cell lymphoma or high-grade B-cell lymphoma in clinical practice? I think we have discussed, but like as a concise thing, if you want to understand from the esteemed panelists, Dr. Sanjeev, Dr. Nivedita, Dr. Ankur, whoever can please educate all of us that how do you differentiate in clinical practice whether it's a lymphoma or it is some other high-grade B-cell lymphoma, and what do you do for that?
Yeah, Meet. So actually, clinically, it's difficult to say whether it's a high-grade lymphoma, B-cell lymphoma, or DLBCL. But as per literature, what they have mentioned is that in high-grade B-cell lymphoma, you will have more of extranodal presentation, and CNS involvement is also slightly more common in high-grade B-cell lymphoma compared to DLBCL. So these are few markers, clinical markers, which can help us in knowing whether, but still it's like very difficult clinically to say which type of lymphoma will be that among these two.
I think one important feature is that blastoid morphology is usually it goes in favor of high-grade B-cell lymphoma versus a DLBL. So it's mostly, I think, a morphological diagnosis.
Yeah, clinically it's difficult.
Clinically, it is difficult to distinguish.
I am giving you just an example. Today, I have seen one patient who has two masses, one sacral mass, one.
The lab part. The other is definitely the lab part of it that includes the morphology. And does immunohistochemistry also help us in any way?
Most of these high-grade B-cell lymphomas, which are double hit, triple hit, they are GCB origin. So that is one clue.
Absolutely. Yes. So that's so right that the germinal center origin usually can point toward, and the morphology can point towards probable high-grade or aggressive B-cell lymphoma that someone is dealing with. And any other opinions, any other thoughts for this? Like any other way we can sort of suspect that this patient particular who is walking into OPD can have a high-grade or aggressive B-cell lymphoma?
But actually, it's not a clinical thing that if you see any GCB type of DLBCL, are you going to work up him for high-grade B-cell lymphoma upfront to all such patients? Are you going to do IHC or translocation for all these high-risk CMYC or BCL610 2? So I don't know whether we are treating all GCB, DLBCL. We are screening them for a high-grade B-cell lymphoma or not. Usually it depends on other parameters, as I told, if CNS involvement or if patient is not responding to R-CHOP chemotherapy or something like those parameters which can help us in screening those patients or segregating high-grade B-cell lymphoma patients. Though GCB
I think
is the most
absolutely right.
common subtype remission.
Yes, absolutely right. So GCB is the most common type, but based on GCB alone, it might not be sufficient for us to screen for a higher grade lymphoma. But possibly with the expression on IHC of CMYC or BCL2, someone might have a suspicion that a double hit lymphoma might be underlying. So that is what. So for those patients of general center who are negative for CMYC, maybe to say that this might be having a high grade lymphoma might really be difficult. And that is what the previous chart that I was showing was depicting, that those high grade B-cell lymphomas who are negative for double hit lymphoma, most of them will express CMYC positivity. So CMYC is an important IHC marker that possibly should be done for all high-grade lymphomas, aggressive B-cell lymphomas, and that is the first point of gateway for entry for the suspicion of a underlying double hit lymphoma. So CMYC positivity is a first marker that should possibly done as a routine marker for analysis of lymphoma. That is one thing. So how do you manage this particular patient who is typically CMYC negative, but still possibly high-grade lymphoma based on the blastoid morphology? And how do you manage this particular patient? Would you change your management or you will go conventional R-CHOP way?
Amit, my one first question before going for treatment. Actually, do you screen all patients for CMYC by IHC or by IHC before starting treatment? By
So this is a
IHC or
discussion
by...
In our
we
center,
usually
CMYC
have
is a
with
part of the
the
panel.
It's not in our center, so actually that's the issue.
Sir, in our center, it's a part of the panel. CMYC is
Actually, I
part
have
of
to
the
outsource
IHC
it.
panel.
If I have to get it done, I have to outsource it, and it takes around 2 to 3 weeks for me to get the report. So as a first treatment, my first line of treatment is R-CHOP to all the lymphomas. And in those, I am suspecting high-grade lymphoma or like double hit, triple hit, then I have to send that sample outsourced. So that is the thing. So screening is not that easy here.
But what do you send? Then you send a fish test or the IHC on CMYC? What do you send, Dr. Sanjeev?
Then I send for translocation, not for IHC, like CMYC, fish by CMYC, for CMYC.
One more thing, Dr. Meet, that most of the double expressors are ABC type. So I think there are two distinct entities, double expressor and double hit.
Absolutely, absolutely. So that is what I'm trying to say, Dr. Nivedita, in the curve that I showed previously, that CMYC positivity is a gateway to entry for suspecting a double hit lymphoma. Agreed. Out of those 30% population, only 10% population
will actually turn out
to be fish positive. Rest all would be negative ultimately. So for this particular patient, any change in management, or you would go the conventional R-CHOP way?
It depends on the diagnosis. If you have made a high-grade B-cell lymphoma diagnosis, then treatment should definitely be not R-CHOP. And if it's DLBCL only, then R-CHOP. So that's the entry point. You have to decide at the entry point.
Absolutely, absolutely right, Dr. Sanjeev. So what I was trying to say in one of the previous graphs again is that even if it is a high-grade lymphoma but a lower IPI, probably R-CHOP might be sufficient. So even if you have identified as a high-grade lymphoma, but IPI might guide us in that setting also for the treatment decisions. If it is a limited stage disease, it's not a high grade, it's not a high IPI disease. Probably R-CHOP-based treatment might be sufficient in such patients because this is not a typical double hit lymphoma. It's a high-grade B-cell lymphoma for which the data for all type of intensive treatment is still developing, and there is no hard evidence so far in this subcategory of high-grade B-cell lymphoma, non-double hit, triple hit lymphomas, that is high-grade B-cell NOS, to treat all of them with a intensified treatment. That is what I try point. That is what it was I tried to highlight in this particular case. Like this is debatable. I think everyone will have a different point of view. But yes, like my point of view is that for low IPI with non-double hit high-grade B-cell lymphoma, probably a lower intensity treatment may be justified.
Dr. Meet,
so that is my viewpoint, but yes, that is contradictable by everyone. Yes, Dr. Ankur.
Yeah, are you doing fish for all DLBCLs? In my practice, what I do if I get CMYC positive on IHC only, then we send for the fish. Otherwise, we treat it like DLBCL only.
Absolutely right, Dr. Ankur. That is what we were discussing just now. So that is what we were saying, that CMYC is the entry point to suspect a high-grade lymphoma. So that is what we were saying. And in those patients who have got a CMYC positivity, strong positivity more than 50%, for those patients, probably sending a fish sample may be justifiable and to bear the cost and things like that. So probably again, the message for this is, as we can say, there is heterogeneity amongst opinion. Dr. Sanjeev wants to treat this patient with an intensified regimen, and probably I would slightly be reluctant to go a high grade intensity. Dr. Ankur, Dr. Nivedita, what would be your
The point is, sometimes
choice of treatment for this particular patient?
Sometimes what happens,
I
like,
would probably still go for R-CHOP.
Okay.
yeah, means for DLBCS, I would go for the R-CHOP, but when it comes double hit and triple hit, at that time, if the patient is young, we think of giving dose adjusted epoch. The question arises when CMYC is positive on IHC, fish has been sent. And at that time, what we should do is it takes around 15 days, 7 to 15 days for the IHC fish to come.
Dr. Ankur, Dr. Sanjeev, you want to say something for this?
No, in your case, probably R-CHOP will be the better because CMYC is negative. We can go with R-CHOP. But yeah, it depends. Like, I will go with R-CHOP in your case.
Ankur's question, you want to say something like CMYC fish for CMYC you have sent, that takes 15 days. During that time, what do you treat with?
Actually, I had one case. I started him on R-CHOP, and when the fish report came, then I changed it to Dipocar after in the second cycle and onwards. So that's how.
So probably first cycle like a pre-phase can act, and then subsequent cycles can be the correct treatment.
Yeah.
Okay. So I think the next slide, please. Sorry, Dr. Ankur, I didn't ask you what will be your treatment or choice in this particular case. Non-double hit high-grade B-cell lymphoma.
In non-double hit high-grade lymphomas, I would like to go for R-CHOP only. And if the CNS IPS is high, then methotrexate, intrathecal methotrexate is one which I would like to consider.
Perfect. So I think this we have already discussed. This is just the literature of that. The high-grade B-cell lymphoma is a distinct entity. HGBL NO is a distinct entity that comprises high-grade lymphoma, non-double hit, triple hit lymphomas, and that are again distinct from DLBCLs also. It's important to identify them because the data is slowly creeping up in this subset of patients also to sort of intensify the treatment, but that data is still too mature. The high-grade lymphomas constitute 30% and things like that we have already discussed. Next slide, please. Next slide, again, this we have all discussed. We can come to the second case. That's the only case, two cases we have. This one is a 39-year-old male who runs a jewelry shop. He has no comorbidities and he comes with a swelling in the neck region for the last 1.5 months. Next slide, please. So his cervical lymph node biopsy that was done shows sheets of intermediate size atypical lymphoid cells with complete effacement of the lymph node architecture. The immunohistochemistry that was done shows a Ki of 75%, CD20 positive. His lymph node biopsy is CMYC positive by 60%, and BCL2 on IHC is again positive by close to 75%. So CMYC and BCL2 positive on IHC. And his is negative, the negative for CD10 and BCL2. So just implicating that this is a non-GCB origin who has possibly at present a double expressor lymphoma. And so the PET CT that was done that showed lymph nodes on both sides of the diaphragm, and there were two extranodal masses. One was a large paravertebral mass, approximately 5 by 3 centimeter in size, and another pelvic mass that seemed to be originating from bladder, urinary bladder, and that measured approximately 3 by 2 centimeters. So with this data, the next slide, please. So what we can interpret is this is a high-grade double expressor, non-GCB type, who has got a RIPI poor because of extranodal masses, high LDH that was not mentioned here, and extensive disease, although age was not on the poorer side. And he has got a CNS IPI high risk because of the involvement of two extranodal sites. So with this background, we open up for the questions. Next slide, please. So the first question is, do you do routinely fish testing for all your patients who you suspect on the basis of morphology or IHC to have a double hit lymphoma? So starting with Dr. Ankur, do you do
Yeah, means if
fish testing for all your
on
patients?
IHC CMIC is positive, then I definitely counsel my patients, if the cost allows, financial allows, to go for the fish testing.
Dr. Nivedita, Dr. Sanjeev?
Yeah, if IHC is positive, then definitely this should be done.
I think with such an IHC report, yes, fish is warranted in such a case.
So fish testing should be done, and that probably we all of us agree it could be done. But the limitation part of it, how many of us are actually able to do it? So CMIC has come positive, maybe for 10 patients, out of 10 patients, how many of would you be practically able to do it?
I didn't get your question, Meet. What are you saying?
So suppose 10 patients in your last experience, 10 patients have had come for a CMIC positive IHC report. Out of those 10 patients, how many would have gone for a fish testing in actual practice, roughly?
Hardly.
I think not more,
2-3.
more than 1 or 2.
2-3, yeah.
So out of 10 patients, maybe 2 or 3 or 1 or 2. Dr. Ankur, Dr. Sanjeev Yadav, are you there?
It's about 4 to 5, because there are many patients who are from insurance, so we get it done.
So Punjab is a rich state that we knew about it.
That's all right.
Dr. Sanjeev Yadav, are you there?
Dr. Meet, if I may jump into the discussion, sorry for joining. Dr. Naveen this side.
Hi, hello, Dr. Please.
Hi. Real apologies. I was really late. Fish testing is, as everyone has rightly mentioned, not more than 1 or 2 patients out of 10, maybe even less in the current clinical practice. And it's very difficult to say if based on the IHC alone, we would be able to take that decision. More or less, it is dependent on the financial status of the patient rather than the disease biology. So that's a sad part here.
Okay. So in the actual pretext that we are not able to do fish testing for most of us, we rely on the IHC report. That's actually the practical thing. The similar thing happens with us also. So how do we counsel these patients? So how do we counsel, as in, like, do we actually counsel that you are having a high risk disease and you need to intensify the treatment? And again, the question arises that in clinical practice, how many of these patients we are actually able to escalate the treatment, intensify the treatment other than RCHOP?
No, ideally, if you are getting high risk proven IHC, the fish proven CMIC, then definitely treatment should be upgraded. That is what you are counseling about. Otherwise, continuing RCHOP is not a problem. But if you have to counsel, then everything treatment plan will get changed accordingly. Cost will increase, and even the prognosis will be not that good. So all these parameters have to be.
In clinical practice, for those patients who have, for last 10 patients who have had IHC positive ones for CMIC, how many of us had escalated the treatment from RCHOP to R-DIPOC? That is what I wanted to understand in actual practice.
Hardly 1 or 2 patients. 1 patient, I can say.
1 patient. Dr. Nivedita, Dr. Ankur, Dr. Naveen.
I would agree with Dr. Sanjeev. It is very, DA-EPOC is a very intense protocol. It requires a PIC line. It requires prolonged hospitalization versus RCHOP, which is essentially a daycare regimen. So finances definitely come into play when we counsel such patients. And I like your analogies that this patient is a jewelry shop owner. So you do look at all of that when you plan treatment. So it's not often that I think we're able to offer, as much as we would like to offer DA-EPOC, I don't think practically that is possible.
Nivedita was very particular about jewelry shop. Actually, I missed that.
That line caught my eye.
But I think
you should have more such patients.
I think we should send the patient across to Max Hospital, Noida.
Yeah.
We would love that.
I think
Okay, Dr. Ankur and Dr. Naveen, please.
I think we are asked. Yeah,
Sure.
Dr. Naveen, please.
Please, Dr. Ankur, go ahead.
I think if we are going for an dose-adjusted epoch, if the patient is willing to proceed with the dose-adjusted epoch, he will definitely get the fish test done. And without fish testing getting done, it will be a little bit worrisome to have R-DIPOC on the board. I would go for the RCHOP. I'll counsel the patient's family because the chances of relapse will be high, being this is a high-risk disease. But since the fish is not there, I will not go for dose-adjusted epoch for these patients.
Okay, so you are saying that if CMIC is positive on IHC, but the patient has not been able to do IHC fish for whatever reason, you would go the conventional R-CHOP way.
Yeah.
That makes sense. That makes sense because you
but,
don't want to expose.
What does the
I was
literature
about to
say?
make a similar point. Unless I have a proven double hit lymphoma, I would not change the treatment to anything other than R-CHOP. Only if I have a proven double hit, then I will escalate it to DAR.
But even double expressors are not that as good as simple DLBCL. They also fall in between double hit and double N DLBCL. So
yes,
actually that again, double expressor is not also that good. That's what I mean to say.
Agree. Yes, sir. My understanding is that even in double expressors, although the prognosis is inferior to the other DLBCLs, but whether escalating to DAR-epoch would actually make a difference in the PFS or OS, that is still not clear with double expressors. So, although we know that these would be bad diseases, I don't think escalating would give us an added advantage in such cases.
My apologies, sir. Request you to conclude your panel discussion in 2 minutes. Thank you.
So I think we all are right because, like as Dr. Sanjeev said, that we should escalate the treatment. That's absolutely point well taken. But the only problem is the data that is published so far is essentially for double hit lymphoma and not for double expressor lymphoma. So that's a very valid point from Dr. Ankur and Dr. Naveen as well. That for those patients who have a double expressor lymphoma, probably it might be unjustifiable to continue the R-CHOP way. Just the next slide, please. I think these are the studies that have used. The next slide, please. So I just wanted to highlight that other than intensification of the treatment for double hit lymphomas, what is being tried is this the novel targeted treatments that can be incorporating bortezomib, incorporating lenalidomide, including ibrutinib to the backbone of R-CHOP is something that is being explored and that is being tried for aggressive high-grade B-cell lymphomas, and that should be considered at some point of time when this data matures. So adding len maintenance is another option for elderly patients who have got an aggressive B-cell lymphoma, and yes, these are the options that one can try and be considered about. The last data is about the CNS disease. So whenever there is an external involvement, it just shows that there is a high chance of CNS relapse. And in those category of patients, probably CNS IPI should be considered. And as Dr. Ankur was trying to say, probably that high dose methotrexate with intrathecal methotrexate should be considered for those patients. Anyone else would add, or else we can hand over the session to the organizers.
The point about
Anything,
CNS
Dr. Sanjeev?
involvement and CNS relapses. So recently there has been a lot of data published which has shown that even in the higher risk patients, both intercalated and post-treatment high-dose methotrexate has failed to deliver any benefit in terms of the relapse rates. And the whole practice of giving methotrexate, whether intrathecal or high-dose methotrexate, is, I believe, it is still like up in the air now based on the recent data that has been published in the last 2 years. So my policy is to give high-dose methotrexate at the end of R-CHOP whenever possible. But now I'm beginning to question whether that is actually helping the patients and preventing relapses, or that the high-risk ones would relapse no matter what we do. So that is something that I believe that it's a still very open question now.
Absolutely. Dr. Sanjeev, what is your practice for patients?
Which patients? Like, what are you saying? What is the question? I didn't get it.
With high risk of CNS involvement, high CNS IPI.
Yeah.
So for high CNS IPI, what is your approach?
Approach is like you have to get lumbar puncture done and to prove whether CNS is involved or not. That is the first test. And
if
then
not involved,
intrathecal chemotherapy.
If not involved, but high chances of high CNS IPI.
Then also at least for few cycles you have to give 4 cycles or something that you have to give intrathecal. So that is what is suggested. That
Dr. Nivedita?
Our practice is usually to give intrathecal methotrexate with each cycle of chemo, and subsequently at the end of treatment, sometimes we do incorporate high-dose methotrexate also for 2 cycles. I don't know what it does. Maybe it's good for us, that's the patient.
Dr. Ankur? Your practice?
In my practice, I generally go for 4 doses of intrathecal methotrexate with R-CHOP if the CNS IPA is intermediate or high risk. Instead of giving nothing, at least giving some methotrexate intrathecal will not harm the patient much. High dose methotrexate sometimes causes complications and additional cost to the patient. I agree with Dr. Naveen. With the latest data, they say there is hardly any difference, but still, I think giving intrathecal methotrexate will not cost much to the patient. So I generally go for intrathecal methotrexate.
But no high dose MTX.
No, I don't go for high dose MTX. That's an additional cost.
Okay. I think we also don't go. Dr. Naveen's point is very well taken. So IT MTX with high dose methotrexate is the data. 3 gram per meter square, 2 doses of high dose methotrexate plus 6 doses of R-CHOP is what is the recommendation for high CNS IPI. And probably, yes, that is what should be done. But I agree to that. Most of us, including us, we are not doing that high dose methotrexate part. We do incorporate the IT MTX, but not the high dose MTX part. But yes, anything else? Anyone else wants to add anything, or we can conclude the session with this?
I think we are running short. We can conclude.
Okay. Thank you so much, Dr. Sanjeev, Dr. Navita, Dr. Ankur, Dr.
Thank you, Dr. Meet. Thank you, organizers.
Thank you so much for a wonderful session.
Thank you, Dr. Meet, for this wonderful moderation for the high grade DLBCL. And now we are moving to next session. How do I treat MDS? For this, I would like to invite Dr. Arihant Jain, who is a clinical hematologist at Department of Internal Medicine, PGI Chandigarh. So what is the current and emerging treatment option for the MDS? And for this, I would like to invite Arihant Jain, please. Dr. Arihant Jain, are you there? Yes. Dr. Arihant?
Yes, hello, everyone. So, am I audible clearly? Just wanted to
yes, yes, sir. You are very much audible, sir. Yes.
And is my screen visible?
Yes, sir.
So, first of all, I would like to thank the organizers and Dr. Sachin, who is a dear colleague. We both practice in the same city, and shifting gears from lymphoid and plasma cell disorders to more difficult to treat population, rather, I would say, which is high risk MDS. And I've been asked to review the current and emerging treatment options. So the outline would be the introduction, establishing the diagnosis, risk stratification, standard of care, and emerging therapies. I would stick to only high risk myelodysplastic syndromes and kind of omit the low risk group. So we all understand that myelodysplastic syndrome is rather a very heterogeneous group of malignancies that is characterized by distorted hematopoietic stem cell function. More and more it is being recognized that there is an inflammatory and innate immune dysregulation which is happening. And at the same time, there are multiple genomic events which are happening at a molecular level. The other thing is that the majority of patients with MDS will die from complications of MDS per se, i.e. cytopenias, rather than as a result of transformation to AML. And there is more and more data to suggest that there is a link between the development of CHIP, MDS, and cardiovascular diseases. And also to underline in the very beginning that despite the various advances in the prognostication of these patients, the treatment options continue to be scarce. So the first challenge in managing these patients is to actually classify these patients appropriately. So these are these various 4-letter acronyms which include CHIP, aegis, and aegis, clonal hematopoiesis of indeterminate potential, dysplasia of uncertain significance, cytogenetic abnormalities, and MDS. And so the classification basically depends predominantly on the degree of cytopenias and the extent of dysplasia. And we do, as of now, we do require the extent of dysplasia more than 10% in at least one or more lineage to classify as MDS, and this is the trigger to actually initiate treatment. And we must understand that the amount of somatic mutation which actually is defining the genomic instability of these patients is up to 85% of the MDS patients will have a somatic mutation, and obviously they carry a risk of progression. So to establish the diagnosis, the key lead in is the cytopenias. The cutoffs are quite basically early. Any hemoglobin less than 11, which is unexplained, a neutropenia of less than 1500, and a thrombocytopenia of as mild as anything less than 1 lakh is the point where we should actually be thinking of an MDS, particularly in a middle-aged to an elderly person. Then we would require the decisive criteria, which would include, which currently only include the cytogenetic abnormalities, which are typically described on karyotype rather than a fish, and the presence of dysplasia in the form of either blasts or dysplastic cells. So what is most important to understand is that before we label someone as MDS, a lot of other common scenarios need to be excluded. We have seen patients who were almost listed for transplant, but were found to have actually B12 deficiency, responded to B12, were diagnosed to have viral infections such as HIV, which can produce dysplasia. We had a patient who was on an excessive zinc supplementation, and as a result of zinc which he was taking, he did have a secondary copper deficiency, which led to cytopenias and dysplastic changes in the marrow, and supplementing, just stopping the zinc supplementation and correcting the copper deficiency actually led to the improvement of dysplasia and cytopenias. Obviously, the medications, the autoimmune conditions, and the other related marrow failure syndromes need to be excluded very precisely before giving a label of MDS. So this is the complicated WHO 16 classification of MDS, and that basically includes 4 parameters: the extent of dysplasia, the degree of cytopenias, the presence of sideroblasts, and the routine blasts which were there, as well as cytogenetics. So based on this, the various categories have been laid, and it is the MDS EB1 and EB2 which most frequently fall in the high risk group, while the other ones often are the low risk ones. So, and the prognostic system, the most commonly used is the IPSS-R. Again, it is currently relying mainly on karyotype, bone marrow blasts, and the cytopenias. And we know that anything beyond more than 3 classifies as a intermediate and high and very high risk MDS. The cytogenetics is very important, and currently it is recommended that it has to be a conventional karyotype, which has to be done rather than a targeted fish. And though it has its own drawbacks in terms of the yield, but still the recommendation is a 20 metaphase karyotype. And we know that the very good ones can have a median OS of as long as 60 months, to the ones with complex abnormalities which have a median OS of up to 5 months. And obviously the monosomy 7, the extra chromosomes of 21 and 8 actually, which form the majority of the group, a significant proportion of the group form the 20% of the patients. And this is the basically median survival, which was established in 2014, and very low, having a median survival of 8.8 years to as low as 0.8 years in patients who had a very high risk IPSSR. So basically defining the risk group would actually, if you are using the IPSS system, it is the low and intermediate one. But if you are using the IPSSR, it is the very low, and some subsets of intermediate, which would still be classified as lower risk disease. And while some subsets of intermediate as per the IPSSR would actually be classified as high risk disease. So this is what is the actual limitation of IPSSR. And because the intermediate category does have a very heterogeneous prognosis, and IPSSR does not take into account the various comorbidities which these patients very frequently have because of their age. It is only validated for patients with de novo disease, while the patients who had previously received genotoxic therapies or are having a inherited marrow failure are actually excluded, were not included in the initial IPSSR evaluation. And this is why a lot of newer prognostic scoring systems are being looked at, and there is more and more emphasis on the basically the degree of genomic mutation profiling which these patients are harboring, in addition to the dysplasia and cytogenetic abnormalities and cytopenias. So even so, there would be a lot of that intermediate. So in the intermediate IPSSR category, who would be the ones who would actually be upstaged into the high risk category and would actually be the candidates for more intensive therapies in terms of allogenic transplant are the ones who have a more severe degree of neutropenia. There is a rapid fall in platelet count, there is ongoing transfusion dependence, there is an inherited predisposition which you are suspecting, there is a lack of response to the original low-risk therapies such as lenalidomide or erythropoietin stimulating agents. The patient has a significant degree of fibrosis on the marrow, or if he is harboring multiple mutations, either in number, which is more than 3 mutations, or the TP53 RUNX and ASXL1, which we know are bad, even if the patient qualifies as a low risk in IPSS. So the somatic genomic, there is more and more data to suggest that even in the low risk group, if you are able to the patients who are harboring these 4 or 5 mutations, the TP53, EZH, RUNX, ASXL1, and ETV6, they would have an inferior prognosis. And so that is why these would actually be upstaged into the intermediate or high risk category, and would rather you would be actually considering a stem cell transplant here early on the course. So this is why the genomic profiling is becoming more and more important in refining the prognosis of MDS patients. And I think these mutations do hold a independent prognostic value. Even the allelic nature of the TP53 mutations, which often we get an idea with the VAF, it is the biallelic TP53 which is associated with an inferior prognosis. So, and at the same time, you have to understand that these mutations continue to evolve, and it is not the one single time point where these should be assessed. Rather, they should be assessed serially whenever you are assessing the response. And the other important thing is that in case you are able to capture one of these NPM1, FLT3, SEPA, these are more typical of a AML kind of a disease rather than a MDS kind of a disease, and these would be the ones who would rather benefit from a typical AML kind of a treatment algorithm. So at the same time, there is more and more data to suggest that a lot of these patients are actually harboring an inherited germline predisposition, and the number of genes which are associated with a germline predisposition continues to increase. And the previous concept that predominantly germline mutations occur in a pediatric or a teenage population is actually being challenged. And so even the physicians who are catering to adult patients should be aware of these germline predisposition syndromes. There are, I would not go into the various syndromes, but just to make a point that the SAMD9L is being increasingly recognized in the monosomy 7 or the deletion 7 subgroup of patients, and the remaining others which we all know of. So the two questions with regards to the initial diagnosis and risk stratification, in addition to what was being conventionally recommended, should molecular profiling for somatic mutations be routinely used to guide risk stratification in MDS? I think the answer is yes, and that is what the most of the recent recommendations suggest. Should IBMF mutation panel be done routinely in all patients? The answer to that is still no, but at the same time, we should be cognizant of the fact that age alone may not be the only criteria to rule out an inherited predisposition. You have to go into the family history, a deep physical examination, and look for the typical, one should be aware of the typical phenotypes of the various syndromes which are described. So the conventional approach has been for the diagnosis and prognostication of MDS has been restricted to a blood count, a marrow aspirate, biopsy, and cytogenetic analysis, and subsequent risk stratification. However, there is the emerging concept is that in addition to the clinico-morphological data and cytogenetics, you need to incorporate molecular data and tailor the treatment according to that, rather than relying only on these two characteristics. So the emerging approach is to use more of a IPS molecular integrated scoring system, and the therapeutic decision should take into account these molecular abnormalities as well as you should be sequentially evaluating these mutations because of their evolutionary nature. So with this background and once a reasonable a diagnosis of high risk MDS has been made with reasonable confidence, you need to decide on therapy. Basically, the factors which you need to consider obviously is the risk stratification, feasibility of HSCT, because that is the only curative option here, the age, comorbidities, the genomic profile, and in Indian context, the availability of finances and supportive care do play a role. So the goals of therapy in low risk MDS predominantly are restricted to alleviating the symptom burden of cytopenias. However, in high risk MDS, not only we have to alleviate this symptom burden of cytopenias, at the same time we have to halt the progression to myeloid leukemias, and this would actually mean that we have to look at therapies which would actually be reducing the blast count, and in cases who are eligible, should be able to bridge to LOHSCT. At the same time, we have to manage a lot of comorbidities, and this intermediate group is actually the heterogeneous group where the molecular data helps us to decide whether we have to go the low risk way or the higher risk way. So this is the current standard of care algorithm which is there for high risk MDS patients. You first thing to assess is whether the patient is eligible for a transplant or not. If yes, then you would you may consider a few cycles of HMA. There is more and more data to suggest that iron chelation is important, and then you should be taking them for allogenic transplant. On the contrary, the HCT ineligible patients would go to the standard hypomethylating agent route, and if they fail that, then, which is not infrequent, we would be exploring the options of targeted therapies. So basically, hypomethylating agents are the current standard of care for high-risk MDS patients, and we all know that the ASA 001 trial established the efficacy of these drugs, and although various dosing schedules were explored, but it is the standard 20 milligram per meter square decitabine 5 by 28 days or 75 mg per meter square IV or subcu ASA, which were making the difference and were leading to improvement in transfusion requirements as well as delaying progression to AML. So there have been meta-analysis that compared decitabine to azacitidine, and in terms of survival, they could not prove superiority. However, the decitabine being more myelotoxic showed a higher CR rate, and decitabine at the same time is also showing a higher incidence of grade 3-4 anemias, febrile neutropenias, and thrombocytopenia as compared to ASA. So is there any role of AML-like chemotherapy? We know that as compared to AML, the chemotherapy have a lower CR rate in patients with MDS. The duration of CR is shorter. There are more prolonged periods of aplasia than what is typically observed in AML. So, and the feasibility of delivering these therapies is reduced because of the advanced stage. In patients with complex cytogenetics, this is again not a very good option to go to. So AML-like therapy is recommended only for those select group of high-risk MDS patients who are younger, who have a favorable karyotype, who are eligible for a LOHSCT, and who have a blast more than 10%. And at the same time, the patients who are harboring the typical NPM FLT3 SEPA mutations may also be candidates for intensive chemotherapy. So whom and why to transplant? Basically, the recent JCO publications does show that the patients who had a donor transplant option was a superior option, and there was a significant difference in the 3-year survival as well as the leukemia-free survival. So the idea should be to bridge most of these patients to transplant, but again, transplant is again not an easy way. We have to risk stratify, we have to see the feasibility, age, comorbidities, and genomic profiling, and as well as a response to previous therapy in terms of MRD assessment, molecular MRD assessment before we take them to transplant. So we must understand that if you life expectancy is maximized when HSCT is delayed for patients with low risk disease, while it is maximized when HSCT is performed early in patients with high risk disease. So all eligible patients with high risk disease, they should be considered for transplant. And in low risk disease, the high risk features which I previously went through would be the triggers where you would ask for a transplant. Conditioning intensity, well, there have been randomized comparisons. There were 2 trials, and while one showed that it is the myeloablative way which had a higher relapse-free survival of 68% as compared to 47%. However, the other trial showed that the TRM was higher. So the current recommendation would be to offer the maximum intensity in patients who are deemed fit, while in other patients who are frail, it would be the reduced intensity conditioning which can be considered. So do you need to cytoreduce prior to transplant? The answer to that is not very clear. However, most clinicians across the world do agree that in patients who have a blast more than 10% and are actually being taken for a RIG transplant, and there is an anticipated delay, which is very often due to donor availability and transplant planning, it is better to give few cycles of, say, HMA or some other targeted therapies or intensive therapy, and bring the blast count to less than 10% before you actually take them to a transplant. So once you have transplanted, is there a role of post-transplant maintenance with HMAs? Well, the answer to there was a randomized trial which was recently published and it failed to show the survival benefit. We must understand that the maintenance strategies in the post-transplant patients are not easy to deliver, and probably that is the reason why the oral ASA maintenance in MDS did not prove benefit. So what are the emerging therapies? So one thing which we have to understand is that despite the use of HMAs, the survival is not very bright. It somewhere ranges from 11 to 12 months in the real world setting, though in the ASA 001 trial it was higher. And the patients up to, as we know that only 40 to 60% patients would respond, and the patients who fail ASA have a dismal overall survival of 5 to 6 months only. So, and at the same time, there has been data to say that in patients who fail the hypomethylating agents, it is the investigational therapies or and a subsequent bridge to allogenic transplant that could actually give the maximum survival benefit of up to 13 to 19 months as compared to best supportive care, which only gave a survival of 4 months. So based on that, there are a lot of targeted therapies which are being combined, and they all do carry the azacitidine backbone. The 4 major themes is to give a BCL2 inhibition, which means venetoclax, the anti-47 molecule, which is magrolimab, the anti-NED antibodies, and the checkpoint inhibition. So, venetoclax is rather the most exciting treatment option, which is being which we all are practicing in the AML and high-risk MDS scenario. And the ASA, when approach in patients of MDS, carries an overall response rate of 59%, and up to 63% of these patients could be bridged to transplant. There is a lot of data where the overall the marrow median ORR was 84%. The efficacy both in the upfront setting as well as in the relapse refractory population was up to 61% in the recent studies. So basically, we must understand that even in patients who fail hypomethylating agents, addition of venetoclax can actually lead to a CR, and that option can be tried particularly in patients who are being listed for a transplant. So these are the relapse rates, response rates in relapse refractory patients who were previously exposed to azacitidine. So the other very exciting advance is this new targeted antibody, which is magrolimab. It is actually the do not eat me signal target, which is being hit by this antibody. So this anti-47 macrophage immune checkpoint inhibitor actually promotes tumor cell elimination via macrophage phagocytosis. Just excuse me. So and there has been synergistic effects with ASA, and the overall response rates have been as high as 91%. And what is most exciting is that this magrolimab plus azacitidine is actually working in patients who are TP53 mutated, and we all know that this is the subgroup where most other therapies do fail. Which in July 2020, high-risk MSS and CML, and it carries a response rate of a CR rate of 22% and a marrow CR rate of 32%. So these were the phase 2 study which led to its approval, and basically in July 2020 it was approved for high-risk MDS patients. Then coming to what is the role of oral azacitidine, well, that has not yet show a lot of benefit in the low risk MDS patients in terms of independence of RBC transfusion. And the schedule which was used was 300 milligram once daily for 21 by 28 days. So what to do if patients fail HMA? Well, there are very limited options, as I already told. There is some data that you can use clofarabine in low dose with
My apologies, sir. You have just left with 1 minute to conclude your presentation. Thank you.
Then again, CPX351 is also approved in this setting. The last but not the least is actually the supportive care, which is very, very important in these patients. That includes transfusion support, the use of adequate antimicrobials for fever. Androgens often cause prostatic hyperplasia. The chelation is important. Telestor trial did show benefit in patients who were having a ferritin of more than 2500. TPO agonists typically are not recommended in high-risk MDS patients unless there is a very high risk of a fatal bleed. So the concluding slide is that there is more and more evidence to incorporate the precision medicine in deciding therapy for high-risk MDS patients. Patients with TP53 would actually benefit from magrolimab. The ASXL, EZH2 would go to the HMA route. In the IDH1 patients, we can use the IDH inhibitors. And so this is the total therapy approach which is being now recommended, that in addition to HMA backbone, you should actually be exploring the doublets and triplets. You should try to attain a CR, monitor MRD, and then actually bridge them to a transplant based on feasibility, and even consider maintenance therapies. Thank you.
Thank you, Dr. Arihant, for this wonderful session. And it was really an eye-opener to use AM. Am I audible, Pooja?
Yes, sir. Yes, sir, you are audible.
Yes, yes. I mean, my video is on, right?
Yes, sir. Your video is on.
Okay. Thank you, Dr. Arihant, for giving this wonderful session. And it was really an eye-opener for us to use a 3+7 based therapy, depending upon the risk stratification. And now we are moving to the next session. Next session is on CML by Dr. Ankur Mittal. So hit hard and hit early. So over to you, Dr. Ankur Mittal.
Thank you, Dr. Deepak, and thank you, organizers, and thank you, Horizon, for giving me this opportunity of discussing this topic, that is hit hard and hit early in CML. Thanks to Novartis. I'll try to compile the session early as we are running short of time. We all know that CML is one which is was difficult to treat in about 2 decades back, but after the having TKI on board, so the CML is the easiest easiest cancer to treat, being a single drug daily, once a daily, and the patient comes in the remission. So, but now we have many TKIs available with us. So today my topic is to have second line TKI as first line, so that we hit the patient hard and to give them a TFR and good quality of life. So I'll be discussing as a case base. So we have 30 years old female who is recently married, presented with complaints of acute onset of left flank pain and of increasing asthenia that did not allow her to keep up with her hectic lifestyle. On baseline, the signs of anemia was there. Splenomegaly was there, about 13 centimeter below the left costal margin. It's a massive splenomegaly. 156 by 98 BP deranged lipid profile is there. And on smear, the TLC was high, just 87,000 WBC total leukocyte count with blast percentage of 5%, and myeloid shift is there. Ultrasound showed small splenic infarct and hemoglobin was 10.7. Platelet count is 1.5 lakh. Bone marrow analysis was planned and cytogenetic analysis was sent, which shows Philadelphia positive metaphase is there. And the bone marrow showed the chronic phase of myeloproliferative neoplasm with the Philadelphia positive, that is CML in CP, with 7% blast. So the Sokal risk scoring system was calculated with 1.7. So that lies in a high Sokal risk score with recently diagnosed hypertensive and deranged lipid profile. So what are our treatment goals in the patients who have high Sokal score? So if we think that she's a young female who is recently diagnosed with CML, so our goal is to have deep molecular remission, to provide him TFR, to have safety, and to have near normal life expectancy. So with the presence of newer TKIs and having more advanced treatment, so our goals has changed that achieve faster and early responses, prevent the progression to accelerated or blast crisis, have good quality of life, increasing survival, achieving the probability of TFR, and achieving a cure is our treatment goal. So to establish our treatment goals, so the early molecular response, that is early molecular response is high, and that increases the overall survival and PFS. And it has been seen that if we use second line TKI as first line, so the rates of early molecular response are higher as compared to the imatinib. Achieving deep major molecular response at 12 months is another goal, which gives us an optimal response to the treatment as per the recommendation. And having second line TKI as first line has higher rates of MMR as compared to imatinib as first line. And disease progression to accelerated and blast crisis is lower in the patients who have used first line nilotinib versus imatinib. The overall survival is also increased if we use second line TKI as first line, and fewer deaths are associated, maybe because of the disease progression or because of the complications. So as compared to imatinib as first line. So these are the key predictors. The chances of obtaining responses with the most important predictor for the long-term control of the patient disease at the end of 18 months. And it is reduced in the patients who are high risk as compared to the patients who are low or intermediate risk. As we can see from these Kaplan-Meier curves, the patients who are high risk, that is a brown in color, the complete cytogenetic response, PFS, and overall survival are lower as compared to the patients who are in low risk or intermediate risk category. So our goal to choose first line treatment in such patients who have high Sokal score, we have nilotinib, imatinib, dasatinib, bosatinib, or stem cell transplant. Now having TKI, stem cell transplant is not the first line option. So we are left with either first generation TKI and second generation TKI. So today, will you prefer to initiate the second line TKI as frontline in high risk patients? And in which subset of the patients would you prefer the first line TKI as second generation? And will this, considering second line, will increase the quality of life is an important parameter to be considered. And this is the data which shows, this is an original article from Onco Journal, 2022, which shows the health-related quality of life in the patients with CML receiving first line as nilotinib. So in this, they have shown that the most of the patients, there is increased quality of life improvement with the nilotinib as first line occurs during the early phase of the therapy and are maintained over a time. So the baseline quality of life assessment was 95%, and the rate of overall compliance to the quality of life was 91%. And there is a statistically significant improvement was found in terms of physical functioning, role functioning, or fatigue. And clinical meaningful improvements were found already over the 3 months of the treatment, and which is maintained for the long term. So these are the landmarks from the INEST trial. As we can see, those patients who have achieved the optimal response at 3 months or those who have not achieved. So on the long-term follow-up, 5 years follow-up, we can see the patients who haven't achieved the optimal response, they don't do better as compared to the patients who have achieved the optimal response during the initial 3 months of therapy. And this is again further differentiation, like the patient, there is an improved rate of if the BCR-ABL is less than optimal response at 3 months, regardless of the Sokal score, they do better on the long-term follow-up. The patients who are at high risk, and if we started nilotinib as first line, they do comparatively much better as compared to the patients who have started imatinib as first line. So this is the further segregation nilotinib high risk and low risk patients. So this patient, continuing to the case, so this patient was starting on dasatinib as upfront. However, the patient developed grade 3 pleural effusion, which did not resolve with the dose reduction, and the patient was requested to change the therapy because of developing pleural effusion again and again. In our experience, how important is to manage the comorbidities of the patient, and does it have any bearing on the patient's CML outcome? It's definitely yes. The patient is a CML, and we have counseled somebody that the treatment is going to be very easy, just one tablet a day, and the disease get controlled, and the patient has to suffer such comorbidities on and off with the treatment is one which we have to discuss. So this is the scoring system, Charlson's comorbidity index. Most of us are not using in the routine practice, but this has shown that the patients who have the scoring point more than 3 had significantly shorter survival after the diagnosis, those who scored less than 2. So this is one which has to be taken care while deciding the treatment and while counseling. Various parameters are there which helps to calculate the scoring system. So while choosing the TKI, do we have the cardiovascular evaluation every time for each and every patient, and do we do lipidemic and hypertensive profile for the patients while choosing TKI? The answer is yes. Most when we are going for the second line TKI, the hyperlipidemia and hypertensive profile is definitely going to be done, and at least a baseline ECG is one which definitely has to be done. And next is the history of the patients regarding the vascular occlusive disease. So this is the data which shows that CVE rates are higher with second generation TKI than with imatinib. And on meta-analysis, this has shown that second generation TKI, even with dasatinib, dasigna, and ponatinib and bosatinib, there is increased risk of the thrombotic events as compared to only the imatinib. So what are the risk categories which we can consider? So for that, there is a Framingham risk category in which these are the scoring systems by which we can calculate the score. If the score comes high, that is more than or equal to 20, or in the intermediate category, that is more than or equal to 10, or less than 20, or if it is low, that is less than 10. So the coronary heart disease risk at 10 years in percent can be calculated with the help of this scoring system. In low risk patients, about 10% or less than or less have the risk of congenital heart disease, coronary heart disease, while in intermediate 10 to 20% patients have. While in high risk, it is 20% or more, the patients have the risk of developing coronary heart disease. So for this, in our patient, this is a 30 years old female who have elevated cholesterol is there and hypertensive, not on therapy. So the Framingham score was 6. So it is in low category. This was the cross-sectional trial, which compares the incidence of these vascular events in different types of TKIs. And this have concluded on nilotinib, dasatinib, and bosatinib. And they have reported differently in each studies, and thus the CV frequencies cannot be differently compared across the studies. So in this, even the incidence of nilotinib, the CV is high in nilotinib as compared to the dasatinib and bosatinib. But they say the studies populations were different, and they are studied in different study groups. So they can't be compared independently in each. And there is a risk of these cardiovascular events with second and third line TKI compared to the imatinib, and Framingham generally CV risk score at baseline continue to be the predictive factor for developing the CVE in all the TKIs. Coming back to our case, so in our case, we have reinitiated nilotinib as 300 milligram, and at 3 months of the treatment, so the BCR-ABL achieved was less than 10%, and patient continued with the nilotinib. The next question arises that how frequently we monitor. We generally follow the ELN guidelines at 3, 6, and 12 months. But as per the standards, as per the studies, they shows that the frequency of monitoring, as we increase the standard of monitoring, the chances of missing accelerated phase of blast crisis decreases. So the retrospective claims that the study that more than 1,000 first-line TKI treated patients assessed inpatients or medically crossed over the 12 months. So this is again the same that about 3 to 4 tests should be done averagely, or 1 to 2 tests should be done every year, or 0 tests should be done every year. So this retrospective study again claims the same. So our patient is managed on nilotinib 300 milligram BD, and BCR ABL was the log 4.5, that is deep MMR, at 2 years, and he is on under regular follow-up, and adherence to treatment is also good for these patients. So the next is, can we prescribe them the TFR? So we already know the 10 years data from the instant trial that from 5 to 10 years, additional patients achieve deep molecular response, with more patients initiated on nilotinib and continue to meet this milestone. The efficacy of molecular response in nilotinib, the median time to first MMR is shorter with nilotinib, that is 8.4 months as compared to 14 months with imatinib. And the time for the first deep MMR is 37 months. Median time to first is 37 months as compared to the imatinib is 41 months. In our opinion, is it effective strategy for the patients to continue with the therapy or consider TFR? Yes, TFR is one which has to be given to the patient who have achieved the criteria to undergo the TFR, but compliance and counseling is the one which needs to be discussed with the patients regarding the serial monitoring of the RT-PCR. So the green criteria shows the inclusion criteria for the patients who can undergo the TK withdrawal. So the inclusion criteria are whose focal index is not high. BCR ABL transcript at the diagnosis is the typical one. The chronic phase remains. The optimal response is there with the TKI, and the duration of all TK therapy is more than 8 years is one which is really, and the deep molecular response has been achieved, and the deep molecular response is attained for more than 2 years. Then we can plan the TK withdrawal with continuous monitoring. In conclusion, the high-risk focal CML patients have higher risk of progression in the first 5 years. The choice of treatment depends on the patient's goal. The subset of patients, the second generation TKI may be the choice. Managing comorbidities is an important, and cardiovascular risk factors is not an absolute contraindication to nilotinib. The decision can be taken on the basis of Framingham score. 3-monthly monitoring improves the compliance and early identification of disease progression.
Dr. Ankur, I do have one question, although we are running short of time.
Yeah.
Sir, are you? Am I audible, sir?
Yes, sir. Yes, sir. You are.
Do you practice TFR?
Yes, sir. In the patients, those who are on second generation TKI, and generally the patients ask, so can we stop? Currently, I have one patient who is in TFR, and there are 3-4 patients with me to whom I have already consulted regarding the TFR. So once they remain in deep molecular response for more than 2 years, yes, they are willing to get the regular monitoring and to proceed with TFR.
Okay. Thank you so much. Thank you, Dr. Ankur, for this wonderful session. Now we are move to the next session. So for the next session is head and neck oncology. So I would like to invite. I mean, this name doesn't require any introduction. Pooja, am I audible?
Yes, sir. Perfectly
Yes, sir.
audible.
Yes.
Okay. So we are. I think we are running. Okay. It's okay. We are just running 20 minutes late. Okay. So next session is head and neck oncology. For this, I would like to invite Dr. Professor T.P. Sahu. This name doesn't require any introduction. He's a senior consultant and head of the department in medical oncology at Silver Line Hospital, Bhopal, and I would like to also invite Dr. Rajat Bajaj, our dear friend and senior consultant medical oncologist at Fortis Hospital, Noida, to see high dose cisplatin versus weekly cisplatin based on chemoradiotherapy in the management of locally advanced head and neck cancer. Professor T.P. Sahu, please.
Thank you for those kind words. No, not a professor, just a
Okay,
doctor.
no problem, sir. You are a teacher to most of us, so
no, thank you.
Professor as well.
So my screen is 1 minute. My screen is visible.
No, sir, not yet.
Shit. Yeah. I'll just share. 1 minute. I'll just share. Is it okay now?
Yes,
Yeah,
sir.
please go to slideshow mode, sir.
Okay, so that thing is okay. It's not full clear slide is not there. 1 minute.
Sir, click on share screen button, then click on screen.
Yeah, it's
click
okay.
on share.
I have an older
Yeah.
version of the laptop now, so
Oh, no problem, sir. Now
yeah.
you can go ahead, sir.
Yeah. So thank you for the kind words. And Rajat is there. Rajat.
Yes, sir. I'm there.
Before I
Closely.
start, one simple thing: weekly or once in 3 weeks. क्या करते हो in definitive setting?
So we can reserve. We can
Okay.
reserve.
So, friends, what I want to say is the laugh and the face of Rajat speaks it out. So I don't know whether we need this debate or not, but I will just try to convince whatever 1 or 2 persons in the outliers who are still practicing once in 3 weeks in the definitive setting. So point is, in the next 5 to 8 minutes, I won't be speaking long in this one. So it's a weekly versus once in 3 weeks cisplatin in the squamous cell adenoid cancer in the definitive setting is what is the topic that was given to me. I'm sure that's what Rajat is also got as a topic. Okay. So what my things, what I'm trying to cover, I'm looking at most of the practical issues. I'm just going to speak about 4 or 5 trials and not much of a level 1 evidence in the setting. Lot of the data is just evolving. Most of them have been retrospective. So I'll be speaking on the efficacy. The evidence definitely will be there. The toxicity tolerability are 2 big issues which we'll be speaking. The cost issue is there is no direct publication on it, but let's now try to extrapolate from the toxicity data, because all of us know cisplatin is a cheap drug. The major cost will be the radiotherapy component, which will be common for both of it. And one of the major component will be toxicity component. So patients who will have more toxicity will be paying more. And is there Indian data? And Dr. Atul's team has made my job easy. I think that data is something that has been a lifesaver for a level 1 evidence from AIMS. The data is just going to be up in ASCO this week. So do we need to look beyond that? So these are my ways how I'm going to talk about it. I did a little bit of things. I think Rajat also saw that in the medical oncology group. I just put up a Google survey yesterday only. Lucky to get some 60 odd response. So I thought, let's see. Dr. Atul's data is not there in the public domain, is going to be pushed up this week in ASCO. What is the preferred regimen? If cisplatin is the drug of choice, we do assume that patient is eligible for cisplatin. And Rajat, do you see that 80% of our colleagues feel weekly cisplatin is there to be given as a concurrent for the definitive intention of chemoradiotherapy? If I take the 30% also, it's a whooping 85%. Only 15% have opted for 100 milligram per once in 3 weeks. That is our Indian doctors, our so-called colleagues who are well read and do practice every day this concurrent chemotherapy. And the next question was, in the definitive setting, is weekly cisplatin compared to 3 weekly? 75% feels yes, it is comparable and the efficacy looks very good. So with this, I just looked into the trial. And this is a very good meta-analysis which have been put up. And actually, this is Kumar and Vanita are 2 co-authors for this international collaboration. And they looked into low dose versus high dose. For the low dose, they looked into anything that was not a 3 weekly weekly. And the most of the trials, they felt that some of the trials were sub-dosed, as the Tata one, which Rajat will be alluding, I am very sure, where the dose would be an issue for me. And these were 59 chemotherapy trials in head and neck cancers. And look at this thing, if you're using conventional fractionation, and that's what most of us use today for head and neck cancers. And mind you, most of these are very poor patients. And these are definitive treatment. The weekly versus 3 weekly, if you look at the OS data for 1 year, 2 year, 3 year, 5 year, and 5 year is a good term, both the 3 weekly and the weekly look comparable to us. And look at the curves here, they just overlap on each other. So this is from 59 trials, and of these, few of the trials which had a weekly versus 3 weekly as a comparison, those trials were taken up, and this is what it was as per the hypothesis generating. And just look at it. If you just go ahead and read into the text of it, in patients where they looked at definitive therapy, they felt that the patient's adherence was much better for weekly, and this was statistically significant. This was 71% versus 88%, a difference of around 16% in the terms of compliance if you took a weekly in the definitive setting, and that is statistically significant from this trial, which was a multi-country collaboration as a meta-analysis. It's not a trial exactly. They looked into multiple trials. Why this is important? All of us know that if the compliance is not there, if there's a treatment delays, radiotherapy delay of a day also does matter in the terms of survival and the oncological outcomes. Now shifting gears, we know that human papillomavirus is going to be a major way how we are going to take alter our treatment. This is again a data from the Western countries, and this looked at human papillomavirus positive and the negative group, and they looked at the impact of cisplatin dose intensity on this. And just look into it, human papillomavirus negative, because most of the Indian data put it that oropharynx, we have a positive rate of HPV around 10 to 12% or 13%. Some data have shown even single-digit percentage. So we are not a country where HPV is very highly positive as in some of the Western countries. And here look at the green line, which is more than 200 milligram of cisplatin cumulative dose. The blue is 200 equal to, and the red dotted is less than 200. And you see the probability of survival just falling with the decrease in the chances of the cumulative dose of cisplatin, which is not the case of human papilloma. So the take home for this would be assumption that in proven in a larger trial, in human papillomavirus negative, dose intensity is the one of the major factors. In human papillomavirus positive, you could just get away with a low dose, and all of us know that. And this is what was proven in the multivariate analysis. As you see on this side, the cisplatin dose is the major factor which has been showing on the terms of survival for HPV negative group. Why so much of talk on this? Why so much of talk on the cumulative dose? And if you look at every trial which are looked into weekly versus 3 weekly, including our Indian colleagues, all of them would have put this trial up as a reference. And this is a publication which came in 2000, I'm not sure, maybe 15 or 16, and they looked at cisplatin cumulative dose and the importance of it. Why it is important is because if you look at it, for every 10 milligram per kg per meter square of cisplatin, the magnitude of absolute benefit for the treatment rose by 2.2%, a whooping 2.2% for every 10 milligram per meter square dose. And these curves looked at, and they proved that as you increase the cisplatin dose beyond 200, and the efficacy increases even if you reach a 250 or 300 milligram dose. But at least you need to touch that 200 milligram. And most of us agree that 210 to 240 is a dose where we should be consolidating at. So that is where you get the maximum efficacy. So now going forward, this is a data from the Veterans Affairs Group, and this is a data for cisplatin versus 3 weekly versus weekly, and they looked at 40 milligram per meter square, that's low dose cisplatin, versus high dose cisplatin 100 per meter square. Not a randomized trial, but the data numbers are too large for me to ignore. It is 3,000 odd patients, and they looked at this tumor site. Most of them are around hypopharynx and oropharynx, few of them oral cavities. And look at this, the adjusted HR for mortality is no different for a weekly versus 3 weekly. And if you, I'll come to toxicity data in a minute. But this is the trial which really I think will answer all the questions which Rajat even has this in mind. This is the data which is going to be put up and already has been submitted, accepted by ASCO this year from the AIMS and the other colleagues in New Delhi. And it is a number of 278 patients over 3 years. And these patients were for definitive chemoradiotherapy They were not considered eligible for surgery, so adjuvant part goes out. 89% were males. The oropharynx was 60% and the oral cavity was 11%, in contrast to the Tata data where oral was around 60-70%. That was because the majority of patients in Tata trial were adjuvant. Around 93% were adjuvant, only 7% was for definitive chemoradiotherapy. Stage 4A was around 70%. So if you look at it, the positivity for the oral for P16 was 13% in this trial data, which is put up in ASCO. The test arm was a low dose, that's 40 per meter square, not 30, but it's 40 per week. And the control arm was the high dose, because that was still now considered as standard of care. And that was 100 per meter square. And look at it, more than 60 gray or equal, it was equivalent numerically better for the high dose, means 100 per meter square, but statistically insignificant. More than 200 milligram per meter square could be given in both the things in around more than 80%, numerically better for the test arm, this low dose. Responses were superior, although statistically equivalent, were in terms of the weekly. The loco-regional control was again numerically superior by 4%, although statistically insignificant. It was nearly the same number which Tata had, but the difference is here, everyone was for definitive chemoradiotherapy. And if you look at it, this really matches what our colleagues have been doing across in India. We have been doing it for maybe 1 or 2 decades for now. But the most important is this data, which is very, very important for us. The toxicity was more significant in the high dose, that is 100 milligram per meter square once in 3 weeks, for treatment interruptions, for hospitalization and IV fluids, for mucositis, for renal toxicity, for vomiting, and for hyponatremia. If you have this amount of toxicity going on in the 100 per meter square without any added efficacy, which would not only lead to hospitalization and the morbidity, but the pocket is going to be burnt a lot, because approximately, I think more than 1/3 of the patient would require some form of hospital at some point. And this is again reflected in the data which we put up for the medical oncologists to vote for. And all of us, 85%, feel that we have a weekly cisplatin which is better and more tolerable than once in 3 weeks, and only 1% or less felt that the 3 weekly is better. So that is something that is again reflected by this data which has been put up in ASCO. Is this different? Look at the US affairs data and the number of 3,000 patients. Again, it shows the 3 weekly dose is very highly toxic in most of the parameters, as I've already spoken for the Indian data. And not only that, even the negative trial in terms of weekly fed talk for the Vanita's trial also shows that the 3 weekly was more toxic than the weekly. So that is unequivocal that this cisplatin once in 3 weeks, 100 milligram per meter square, is a toxic protocol compared to weekly. So now, move forward. I'm sure if this is not there, Rajat, I've not seen a slide, but if it is there, I just want to put it, this will be shown that the local regional control is superior. The OS data, if you ask, it is similar, but my main criticism for these trials have been the dose intensity. It is 42 milligram per kg per meter square for the 3 weekly, means that the high dose for the Vanita's trial, and for the weekly the dose intensity was 30 milligram only, and that could have made a difference in the local regional control, which is showing. And by mind you, this trial was not superior in terms of OS or the PFS. So the dose intensity was much lower than what people would know. And also we know that from the Japanese data, even in adjuvant setting, 40 milligram per meter square is now shown to be superior to once in 3 weeks in the adjuvant setting. So that is now done, that anything below 40 is not a good dose for a concurrent, and 7% was only for definitive RCT in the Tata trial, 93% for on the adjuvant setting. That's why 80% or more patients in that arm were oral cancer patients. That's why they were operated, and this trial went on. And the conclusion that could be maximally done is from this data is, in the adjuvant setting, they look inferior, but at a dose of 30 milligram per meter square. Even the 40 per meter square in the adjuvant is also now considered to be superior than the 3 weekly. So for me, if I want to wrap up all these things, for weekly cisplatin, 40 milligram per meter square, anything below that is not considered to be ideal dose. Efficacy is definitely equivalent. The Indian data from the Atul Sharma search group has shown that the numerical values could be superior, but definitely statistically they were considered to be non-inferior. Evidence, Rajat, you must be now joking if this evidence is not good enough for us to be getting convinced about the weekly. Toxicity, I don't think there's any data across the Pacific. If you go to the Asians, the Indians, the Western, everyone have shown that the 3 weekly is a toxicity, has more toxicity, it has more dose interruption, the compliance is worse, the tolerability is better for weekly, the tolerability is again worse for the once in 3 weeks. Cost issues, definitely when the hospitalization increases, the toxicity is more, cost issues will be there in once in 3 weeks. And Indian data, I'm sure we have seen the prelude to the Indian data, the whole curves will be shown when they present the data in the ASCO. My point is, if I tell my patient, you have 2 drugs, both are of equal efficacy, but you will have more toxicity for this in terms of A, B, C, D, E, F, everything is bad, but you won't get any benefit. I am very sure any sane person would never opt for a once in 3 weeks. So my conclusions, weekly cisplatin at dose of 40 milligram per meter square is the standard chemo partner in the definitive setting, because this debate was on definitive setting. The tolerability is better, efficacy is definitely equivalent. That's what I would say. I'm sorry for the typo. And we have more of HPV negative, mind you that. And that data again shows from the publication which I showed you that in the HPV negative, dose intensity matters, and that can be only achieved if you can able to push in the dose, and 40 milligram per meter square, 6 to 7 doses will take you beyond the 200 milligram per meter square mark. The only thing which I felt, if someone is still interested after this and wants to go for a once in 3 weeks, you have to go for an altered dose fractionation of the radiotherapy. That happens when you hypofractionate, you are able to finish your radiotherapy quicker. That gives you option of going for a lesser cumulative dose of the cisplatin. And this curve tells you the same thing. This again from the Kumar's 59 trial meta-analysis which they put up, that if you can go for altered dose hypofractionation, then probably 3 weekly is looking superior to weekly, because it does not require that cumulative dose, because you are finishing radiotherapy much quicker. So that is where I stop, and I would like to listen to Rajat what he has to say in his defense.
Right. Am I audible? Hello.
Yes, Dr. Rajat, please go ahead. Yes, you are very much audible. Yes.
Yeah, right. Good evening, everyone. I thank the organizers for having me here, and I thank Dr. Sahu sir for setting up setting the stage for the debate right. And he's had his part of the debate well. And I think I will like to convince him at the end of the debate that 3 weekly cisplatin is the way to go. And there is definitely evidence to suggest that 3 weekly cisplatin is better than weekly cisplatin. And I'm sure he'll change his opinion by the end of my talk. So my submission that high dose cisplatin is the best way to go forward. And first thing which came to my mind when I saw this topic is that is that even a question that we're talking about? 3 weekly versus weekly. 3 weekly certainly is the way to go ahead. But then, of course, Dr. Sahu would say that it is not only on conjecture. There has to be some evidence, because he's very senior and he always delves on evidence. So definitely we are going to give him the evidence, because extraordinary claims do require extraordinary evidence. And we have the evidence. But before that, first of all, let me speak about the guidelines. What do the guidelines say? So we all revere and refer to the NCCN guidelines, but Dr. Sahu sir forgot to tell us about the NCCN guidelines in 2022. But I would like to bring across that if you're talking about a CTRT in the definitive setting, NCCN recommends that high dose cisplatin is a category 1 recommendation in the definitive setting. He may have forgotten to show us. He is a busy medical oncologist. Sir, this is the guidelines which tell us. So is this the end of the discussion already? But probably not. We'll definitely talk about the evidence. So context setting, we're talking about 2 settings. One is the adjuvant setting and the other is the definitive setting. We are delving more in the definitive setting like we just discussed. But just putting the basics right, if I last remember when I checked about the cisplatin ineligibility criteria, the cisplatin ineligibility criteria, there are many and we all know that. It never says that the ineligibility is only for 3 weekly and not for weekly. So if a patient is ineligible for weekly, the patient is also ineligible for 3 weekly and vice versa. But then it is not that the patient is ineligible for 3 weekly and always eligible for weekly. So we have to choose our patients right. I agree that 3 weekly can have more toxicity, but we as medical oncologists deal with many greater toxicities as compared to what it is offered for 3 weekly cisplatin. So probably we know how to really tackle that, but of course I'll be coming to it. And like Dr. Sahu sir said, that there is many previous evidence to suggest that weekly cisplatin has been used, but I would like to submit that there in the many of the past data that we have had, most of these trials have used 3 weekly cisplatin, and it should not be without a reason. So we all know a meta-analysis of head and neck, which is the Malignancy meta-analysis, and this is the update which was presented in Radiotherapy Oncology Journal in 2021, where it very clearly says that if it is a concomitant CTRT used, then there is definitely an improvement in survival in favor of RT plus CT arm as compared to only RT. And importantly, maximum trials used high dose cisplatin in this particular meta-analysis. And if we talk about the use of concomitant chemotherapy, I am sure all of us know, and my esteemed opponent also knows, that it was a 6.5% benefit at 5 years. Agreed that this was RT with CTRT, but most of them used a 3 weekly cisplatin. Now coming to more data, the available data that we have, all trials have used high dose cisplatin and weekly cisplatin both. But look at the intent of treatment. If you're talking about the intent of treatment being definitive, then there is much more evidence of definitive as compared to adjuvant, point number one. And look at this column. So we see that if you're talking about patients receiving all the planned cycles, then in the definitive setting, the cycles received, all the planned cycles in the 3 weekly dose was from 70% to 85%, 86% also. That means more number of patients were able to complete 3 cycles as planned in the definitive setting as compared to adjuvant setting, where they were 60 to 64%. But very importantly, even in the adjuvant setting, when they were completing only 60 to 64%, more than 85% were able to complete at least 2 cycles, which means, like Dr. Sahu very clearly said, that we have to stress on the cumulative dose. Even if it is 2 cycles is 200 milligram per meter square, and this is a magic figure for me. So it is not important for me to always complete 3 cycles, but importantly, in the definitive setting, 3 cycles were being completed by more than 80% patients. And if you look at the intention to treat number of patients, then it was much more in the definitive setting as compared to adjuvant. That is why the debate between weekly and 3 weekly can be probably still there in adjuvant setting, but not in definitive setting for sure. And I've already shown you the NCCN guidelines as well. Okay, but still we move ahead. There is more data on high dose cisplatin in the definitive setting, and all this data does show that high dose cisplatin has been the favor of this for all the trials in the last so many years. Of course, there has been toxicity, but if you look at CTRT versus RT, there has been a C improvement in the local regional control, the distant control, overall survival, and more number of patients in 3 weekly as compared to weekly dose. In fact, when I went on to look at the randomized controls trials, I could see that the only randomized control trials between weekly and 3 weekly were in the adjuvant setting. There was one trial in 2012, which was only 50 odd patients, and another trial, which is the Indian data, which Dr. Sahu also alluded to, had only 92% patients in the adjuvant setting, only 7 to 8 in the definitive setting. Still on the definitive setting, RTOG 9111 trial, the trial that is the most omnipresent trial, all of us will agree. This also used high dose cisplatin, and it showed that radiotherapy with concurrent cisplatin was definitely better than chemotherapy followed by radiotherapy or radiotherapy alone. But this is certainly the only beginning. There is more to come. Of course, we do know that we have to be vocal for local, and we are talking about the Indian data now. So definitely talking about the Indian data, we've already spoken. My opponent has also spoken about the TMH study. This study was actually done to prove, it's a phase 3 study, remember, non-inferiority trial of a weekly versus 3 weekly cisplatin, where the dose of weekly was kept as 30 milligram per meter square, cisplatin of 100 milligram per meter square. Very importantly, one has to know that, like I said, around 7 to 8% only definitive, most of them were adjuvant. But what do we really see? These are the two curves. Dr. Sahu also talk about those, but in a different setting. So if we have the left hand side where intention to treat is loco-regional control, remember this was the primary endpoint. The primary endpoint was not the overall survival. And for me, if you're talking about the primary endpoint being met, it is done for me, and I take this trial as a positive trial. So intention to treat populations showed that the once 3 weekly arm was superior to once weekly arm in terms of loco-regional control. But like he also said that the cumulative dose also matters. So they did a post-hoc analysis where 200 milligram per meter square cisplatin dose was kept, and this was seen that still once weekly, 3 weekly cisplatin was better than once weekly regimen and the loco-regional control. Agreed, the OS data is not there, but this was not the primary endpoint of the study. And if you look at again the same study, this is the forest plot, which says that if the dose is more than equal to 200, then it certainly favors a 3 weekly as compared to a weekly regimen. So we definitely have to keep the dose very much in mind, and it has to be more than 200. The dose intensity always has to be maintained. But then, of course, the very burning question is, this regimen very safe? So this is the safety data. This is Indian data. It's glaring on our face. We cannot ignore. If you look at the median cumulative cisplatin dose in 100 milligram per meter square was 300, 210 in cisplatin, 30 milligram per meter square. Compliance, look at the compliance. More than 95% patients, they completed more than 2 cycles, which was, it was 88.7 in the low dose cisplatin. Agreed, there was increased grade 3 toxicity, p-value being significant, but then the compliance was not bad even with the 3 weekly study, and this is Indian data, so it cannot be ignored. Now, if we talk about high dose cisplatin, this is the editorial. It says that, again, talking about the TMS study and the other 2 studies before that, it says that the results of this trial do not support the replacement of high dose cisplatin given 3 weekly with a weekly dose cisplatin. And it says that not even for the control arm in the subsequent clinical trials. So it goes to that extent. And also it says that the post hoc analysis of loco-regional control rate restricted to patients who received more than equal to 200 still favored the high dose arm. Very important. And the results of this trial should be applied exclusively to adjuvant treatment of HPV negative patients. So we're talking about HPV negative, very correctly said. HPV negative is the most important, where the dose intensity has to be maintained. But then there is more to come. And this is about this trial. So the whole debate is basically of coming in of this trial, which was published in JCO in 2022, which is the JCOG 1008 trial. This trial said that if you're talking about 3 weekly versus weekly, and weekly is 40 milligram per meter square, then probably both are the same. But then talking about this trial in a bit detail. So very importantly, this was a multi-institutional phase 2/3 trial with a non-inferiority design. So we all know that non-inferiority design is not the superior most design that we have. Then talking about the randomization, 3 weekly cisplatin versus weekly cisplatin, and post-op high-risk patients were taken. Now, if they have themselves said that if you're talking about this particular trial, then a non-inferiority margin of 1.32 was taken, and the corresponding 10% of the 5-year overall survival. And if you look at the discussion of this trial, it says that our trial had several limitations, where when we kept the non-inferiority margin of hazard ratio of 1.32, what we were really assuming is that we are allowing for a possible 32% increase in death in the chemoradiotherapy arm with weekly cisplatin. Of course, this is not something which we would allow in our patients. That is why, agreed, that this trial tells us that weekly is almost equal to 3 weekly, but with a non-inferiority margin of 1.32, 32% increase in risk of death, something which is not acceptable. Again, coming to the guidelines and making my opponent remember that the guidelines are very important, and we have to remember that this has been given a preferred category in 2022 guidelines. We're talking about the 3 weekly cisplatin regimen. So to conclude, I would say cisplatin eligible versus ineligible, there is no separate weekly versus 3 weekly data. There are two large phase 3 trials, URTC and RTOG. We talk about that. Both of them had 3-weekly cisplatin. Indian data is overwhelmingly in favor of 3-weekly cisplatin. Cumulative dose is easily reached. Even if it is only 2 cycles, I just need 2 cycles for 200 milligram per meter square. Why not? Indian data says the compliance in excess of 95%. So certainly not a botheration for me in that sense. And toxicity is not a concern if we can do a 2-day splitting also in these patients. Agreed that a bio equivalent study or a bioeconomic studies would say that toxicity can be more, but we can use growth factors and the supportive care can also be taken care of. So with this, I thank you all for your patient listening, and I hope I'm able to make Dr. Sahu change his opinion by the end of this discussion.
Okay, I'll just take half a minute. Rajat, I had totally taken from academic point, you had to defend the things. But I'm very clear it was on a definitive setting. And on a definitive setting, there are only 2-3 trials actually. And the one trial was done and it just stopped because they could not recruit beyond 100 odd patients, 1 weekly versus 3 weekly. The problem with the Tata trial is it is 30 milligram per meter square, and that is going to haunt them for a long time, because these trials cannot be done every decade. It requires a lot of planning. So at that point, and now we all know that below 40 is not a thing to be done. Naresh is there, and I'm sure he will agree that 40 per meter square is the minimum what you're going to do in a weekly. If you look at the cumulative dose, even for a TMH, is 30 for weekly and 42 for 3 weekly. The last thing which is show a median, I also went through the median, it is eyewash. The median is when the 50th thing happens. And if you look at it, the median has to be 300. I just felt how the median can be 300 when around 60 odd patient only could receive 2 cycles out of the 140 patients. So that's when the median happened, because 50th patient or 60th patient received 200. So that 300 median is something we should be not looking into. And it's for post-op setting. Till the Japanese trial came into thing, I think this 30 per meter square business was okay. But once the Japanese trial is out, now full text is out, we had to accept that 40 per meter square weekly is superior regimen. Toxicity better, efficacy equivalent. Any day, any one of us in the census will always go for a weekly rather than 3 weekly. And that's how the practice will change. And with the AIMS data now out, I think it is now a done deal and a fixed deal. People like me who are practicing once in 3 weeks in definitive will now change also to weekly. So that's what I feel. At the end of the day, we debated for the academic thing. But yes, I think this is the way the science is changing and we have to evolve with it.
So you are also practicing once in 3 weeks in definitive?
I used to, because I felt that once in 3 weeks for me was doable. I was scared for toxicity, but now with the data changing, I will also change my practice. I also used to do weekly. I changed after Narona's thing came out. So now I'm going back to the old one of 40 per meter square.
So tomorrow you are going to change. Today you
I've already changed. I've already changed.
Okay, right, sir.
So tomorrow is Sunday. You will change on Monday.
On Monday.
I did it some 3-4 months back.
Right.
Thank you, organizers. Thank you, organizers, from both of us.
Thank
and
you.
thank you for giving us this lovely debate.
Thank you, sir. Thank you.
So you're muted. You're muted.
Deepak Singla, sir, you are muted. So you need to unmute. Yeah.
Yes. Am I audible now? Yes.
Yes, sir.
Thank you, Dr. Sahu and Dr. Rajat, for this wonderful debate. Now we move on to our next session, anti-EGFR versus immunotherapy. And in the recurrent or metastatic setting, I would like to invite Dr. Anubha and Dr. Vikas Talreja for this debate. Dr. Anubha, hand over to you. Over to you, ma'am.
Dr. Vikas, I thought you were going first, but it's okay. I can take it.
I suppose the organizers have the decision to make, but by order, I was supposed to go first.
Yes, sir, you go first. I'll go later.
Perfect. So thank you, Dr. Deepak, sir, for a wonderful opportunity. Thank you, Dr. TP Sahu and Dr. Rajat for setting up a very enormous platform for a lively debate, especially on a Saturday night when everybody is rushing for somewhere, something to go. We will be discussing today the metastatic head and neck squamous cell carcinoma, first line as what to give and what not to give. And without a doubt, everybody at the end of the day would be choosing the
IO plus the chemo combination, as is the rule. Can I ask the organizers to share the slide deck?
Vikas, I have voted for you already.
Thank you, sir. And I'm a winner beforehand also, because on Monday morning, I know Dr. Nuba will also be doing the same thing as we do.
She's already doing it. She's already doing it.
And that's why there is nothing to left to debate. So just I will be sticking to the theories, and that's the number of the new cases that in India we have the Globocan data that head and neck squamous cell carcinoma is quite prevalent, and we have seen that the projected rates are supposed to rise enormously with the relative proportion and the extent of the disease. Most of the disease that we receive in the clinical practice, nearly 70% of them are in advanced stage, and most of them it is the mouth, the oropharynx, that's the predominant in the Indian subset. And when we look at the systemic therapy, we know most of them do present with the distance metastasis. And when we look at the Indian guidelines, I would like the organizers to move fastly because everybody's in a rush right now. And that's why the management of the very advanced squamous cell carcinomas, as was published by the Indian our mentor, Dr. Kumar Prabhash, at presentation, was the local regional recurrent or the second primary with prior. The immunotherapy is there, and also with the distant metastasis, the pembrolizumab is the treatment of the choice for the advanced squamous cell carcinomas. We will go by the Indian guidelines, and we will also go by the American guidelines as they practice in CCN. I will ask organizers to rush fast so they can pack up with what I am speaking right now. The first line is the preferred regimen you would see in recurrent unresectable metastatic situations. There is a unanimous, undoubted opinion that the pembrolizumab plus the platinum, be it the cisplatin or the carboplatin, 5-FU regimen remains the category number one choice, that is highlighted preferred regimen with a CPS score more than 1. Now, PD-L1 testing has been a debacle for everybody. We know that PD-L1 is expressed by a number of the cells, the T cells, the B cells, the NK cells, and it depends upon the tumor microenvironment as what way we will be going to organize our testing and the targeted agent for it. And that's why the score of the 22C3 by the IHC, which is the two methods, that is tumor proportion score and the combined positive score. The tumor proportion score is the tumor positive scores PD-L1 staining divided by the total tumor cells. The combined score is the total PD-L1 staining cells, that is tumor, lymphocytes, macrophages divided by the tumor cells. And TPS is relevant for the pembrolizumab response in the lung cancer, while CPS is responsible for the pembrolizumab response in the non-lung cancer specific types, specifically the head and neck squamous. And why it is different? Because in head and neck cancers, where the tumor microenvironment does play a very important role, and that's why the PD-L1 expression on the immune cell does not improve the predictive value in the non-small cell lung cancers. However, it does have a significant higher sensitivity and specificity in terms of the non-enriched type, as seen in these Keynote 12 and Keynote 55 trials. And the CPS is sensitive than the TPS at the lower cutoffs, as seen in the Keynote 40 trial, as we could see. So multiple layers of evidence for selecting the PD-L1 CPS scores in the head and neck squamous cell carcinomas. We have 5 beautiful trials, the Keynote 12, the Keynote 55, the Keynote 40, and the Keynote 48, all examining the beneficial expedited role of the CPS score as compared to the TPS. And therefore, the preferred SP263, 22C3, or whichever assays we use, even though they have a differential activity, but the CPS score remains the unanimous, undoubtedly role for it. And if
Sir,
we
please say next to go for next slide, because I am not aware when I need to next slide, na sir?
Or probably I will share my screen and then that would be the best thing to do.
Oh, so
Rahul, slides are not moving at all.
No, because I shared from my side when sir told me that please organizer, please share. So that's why. And sir is not saying next, so that's why slide is not moving and I'm not in the meeting.
So again, we will not be wasting much
please,
time.
please
So
click
next,
on share screen button at the bottom side. Click on share screen button, a green color button, sir. On Zoom, sir. And then click on screen, then click on share, sir.
Perfect. Give me a second. you cannot start while the other participants are. Yeah. Is it visible now?
Yeah, sir. Yeah, perfectly visible, sir.
Perfect. So PDL1 is definitely a predictive biomarker in head and neck squamous cell carcinomas, multiple trials. CPS score is there to stay. And that's where we'll rush to the center of the trial. That's the keynote 48, the phase 3 first line pembro plus the chemo for the recurrent metastatic head and neck squamous cell carcinoma. The strict eligibility was the pembro monotherapy, 200 milligram every 3 weekly for up to 35 cycles, pembro plus chemo, as well as the extreme regimen for the chemo regimen. Those patients which were stratified based on the PD-L1 score more than 50 or less than 50, the P16 in the oropharynx, and the performance status. Pembrolizumab was given up to the 35 cycles, and cetuximab was given every weekly for them. The primary endpoint was the OS PFS, the secondary endpoints being the CPS population more than 20, more than 1, the PFS rates at 6, 12 months, overall response rate, changes from the baselines, the quality of life, and the duration of responses. And they designed it very specifically that overall the alpha control at one site should be 2.5 across all comparisons, and it was a superiority study to test for it. Now, you could see that's the real world scenario. There was a good 1 year follow-up, as you could see in terms of the randomized patients and all the baseline characteristics, be it the age, male, the PD-L1 status, the disease status, whether it was metastatic or locally recurrent disease, they were all matched in the either arms, the pembro plus chemo, and the extreme regimen. And that's the progression-free survival. You could look at single agent pembrolizumab with 86% as compared to the 91% events with the CPS score of more than 20, with a hazard ratio of 0.99, and with the CPS more than 1, you could see the median PFS hovering around 3.4 to 5 months. With the chemo regimen being added to it, you could look at the long-term survivals also, especially the follow-up. With the single agent, you could see 2 years, 27% of the patients were long-term survivals, hazard ratio 0.81, meaning a 20% reduced chances of dying from the disease when you give pembro alone with a significant p-value. And 4-year mark, 48 months mark, 15.4% do surviving in a metastatic, recurrent, unresectable, locally advanced head neck squamous cell carcinomas. And if we look at the PD-L1 score with the CPS differentiation, you could look that the graphs clearly separated with more than 20, the CPS score, the hazard ratio was 0.61, meaning a 40% reduced risk of deaths when you give pembrolizumab as compared to the extreme regimen. And when you give in more than CPS 1, you could see 30% reduced chances of deaths when you give pembrolizumab alone, with a median overall survival crossing the 12-month barrier in both of these groups. And if you look at the total response rate, you could also see the duration of the responses, because with immunotherapy, we always know that the duration of response is something which we yearn for, and 24 months as compared to 4.5 months in terms of the extreme regimen. So also in the long-term follow-up, the duration of responses, if we differentiate on the basis of the CPS score, more than 20 or more than 1, again, more than 20 months of duration of response in terms of the pembro as compared to the extreme regimen. So no, it doesn't matter how deep you go, but it's how long you go. That's very, very important when you are discussing with the immunotherapy. And the side effects, you could see graphs hovering high in the extreme regimen as compared to the pembrolizumab, where the grade 3, grade 5 side effects were around 16% as compared to 70% with the chemos. The immunomediated adverse events were definitely something to discuss about. Now, if we combine the two regimen, the pembrolizumab plus the chemo regimen, you could look at the 2-year progression-free survival of 10% of these patients as compared to less than 5% of the extreme regimen alone. And when you look at the 2-year survival rate, the hazard ratio being 0.7, meaning a 30% reduced risk of deaths when you give the pembro chemo combination to the locally advanced or metastatic recurrent head neck squamous cell carcinomas, meaning that this regimen does have a durability of the responses and the depth of the responses with the significant p-values. And if you give the chemos alone, you could look at less than 5% of the people surviving 2-year benchmark. And it doesn't matter which CPS you score, it is more than 20 or more than 1. The hazard ratio was nearly 38 to 36% reduced risk of deaths when you give the pembro plus the chemo combination, with 2-year mark of nearly 30% in the either arm in the pembro plus the chemo in CPS more than 20, and the pembro plus chemo in CPS more than 1. Now, again, the duration of response 7 months as compared to 2.3 months in the chemo arm alone, meaning the durability of response was there. And even if the responses were there, the responses were longer and durable, irrespective of whether the CPS was more than 20 or more than 1. Side effects, as we have discussed in the previous trial, they were extreme in graphs in the extreme regimen, but then in the pembro plus chemo, they were somewhere acceptable as compared to it. To summarize, the long-term follow-up confirmed that the pembro was extreme in PD-L1 CPS more than 20 and CPS more than 1 was significant improvement statistically for the overall survival. The pembro plus chemo versus extreme in PD-L1 CPS more than 20, CPS more than 1, and the total population, there were a significant response. And also the duration of the responses were longer with the combination of the chemo plus IO as compared to chemo alone. And the safety profile also favored the pembrolizumab combination or the pembrolizumab monotherapy as compared to extreme. So what happens when you progress after the next line of therapy following pembrolizumab or pembro plus chemo? You could look at the subsequent lines, and this was the combination that was given when you give who were given pembro alone as compared to who were given extreme alone. You could see that the subsequent therapies, that is, you assess by the PFS2, the second time the patient progresses, it was statistically and hazard ratio was significant in terms of the two groups. So 36% reduced risk of second progression, also the time to the subsequent therapies also when you give the pembro alone as compared to the chemo alone. And also in terms of the PFS2, the 20% reduced risk of progression second time after the first progression with the pembro alone when you give these combinations. And also when you give the pembro plus chemo, again, you look at the hazard ratio, 37% reduced risk of progression second time when you give the combination as compared to give the chemo regimen in CPS more than 20 or more than 1. And if you combine the both, nearly 30% reduced risk of progression second time in the subsequent therapies, also when the patient has progressed on the first line. And what are the usual choices after the pembro plus chemo? It is unanimously the EGFR inhibitors or the chemotherapies or the other immunocheckpoint inhibitors. Now, to summarize, PFS2 was longer for pembro arms in patients with PD-L1 CPS more than 20. PFS2 was longer for pembro plus chemo arms in patients with PD-L CPS more than 20, CPS more than 1, and the total population. The PFS2 data further supports the use of the pembro and the pembro plus chemo as the first-line treatment for the relapsed metastatic head neck squamous cell carcinomas. To summarize, pembrolizumab does improve the overall survival as compared to giving the extreme regimen in the PD-L1 CPS more than 20 and the CPS more than 1. No PFS benefit for pembrolizumab, and we know why it is there, because the responses are durable and there is. So even though they are lower responses, but when you combine with the chemos, they are substantially more durable, and there are lower incidence of grade 3, grade 4 side effects, lower incidence of treatment-related adverse events, and safety profiles as compared to the other lines. To summarize, we have a very robust data to support the pembro plus chemo versus the extreme regimen, and unanimously we would be giving on Monday morning most of them. Over to Dr. Anuba for her side of defense, and thank you for patient listening.
Thank you for that very elegant and scientific argument by Dr. Talreja, my very esteemed and respected colleague. But I will give some counter arguments, and I will say, let's get real right now, okay? We have so far talked about a very beautiful thing, a very beautiful clinical trial, single clinical trial, I will point out, and Dr. Talreja has hung his hat on that. But let's talk about the real world where we are practicing in India. I hope you can all see my slides. And let's talk about our patients. Let's not talk about these patients, some very, like, I would love to have patients like Dr. Talreja has shown us in this keynote 48. I don't think I have such patients, and I would really want to know if you have these patients, because let's talk about whom we are going to see on Monday morning. We have Dr. Sahu has very clearly, and Dr. Rajat has already told us that Indian patients don't do that well. More of them are HPV negative. They are tobacco users. They usually require a really aggressive therapy. And all of us, let's face reality. How many of our stage 4 patients who are metastatic live beyond a year? I think very limited, because unfortunately, the Indian patient with recurrent metastatic head and neck cancer is a very mostly poor patient with very lot of they have not only their PS is poor, they have a lot of social problems, they have had some toxicities from previous therapy, they are usually elderly, frail, they are on feeding tubes, and treating them is really challenging, and it's a very complex process, and it's not so simple as telling them, okay, let's get your CP score. I ask you, how many of us are getting that for our patients? How many of us are sending off the CP score on every patient of stage 4 head and neck, recurrent metastatic head and neck cancer that we see in our clinics? I don't think it will be more than 5 to 10%. And even that, I would be very, very surprised. So we know that our patients have a much heavy tumor burden. They are symptomatic. They have fungating masses. They're unable to swallow. And they need something that's going to give them a rapid response. They need something that's going to prolong their survival. They need something that is feasible for them, and they need to be able to tolerate that therapy. They need to tolerate the 5-FU, they need to tolerate the cisplatin. And unfortunately, that is what is the problem in our practice. Each of our patients is very unique, and we need to personalize their therapy. So before the data for immunotherapy came about, and let me remind Dr. Talreja that the argument, actually the debate was on IO plus chemotherapy versus cetuximab, EGFR agent versus chemotherapy, not IO monotherapy in this CP score more than 20. There was no delineation. So we all know before the IO agents came about, cetuximab plus chemotherapy was the established regimen. We all are very, very familiar with the extreme data. The overall response rate was 36%, OS about 10 months. But then beyond that, we have had multiple trials that have shown us the efficacy of this regimen. There is a consistent response. And in fact, I will argue that in some of the later trials, we have even had, such as the TP extreme, we've had overall response rates more than 50% with an OS of 14.5 months, which is where the OS of the keynote 48 also lies. Let me remind Dr. Talreja that. So we know that this regimen can improve pain, it can improve swallowing, and improve the quality of life in our patients. And let us get back to talking about this 5-FU business. How many of us offer 5 or 4 days of 5-FU to our recurrent metastatic patients? I would love to have done that, the question, the thing that Dr. Sahu did where he asked this question, because I'm sure most of us, and let us be very, 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 very practical, most of us are giving our patients weekly taxane and carboplatin. if we talk about the ground reality. And is there evidence for the use of cetuximab in a non-5FU based chemotherapy? Yes, there is. We have all heard about this TP Extreme trial, where they looked at cetuximab plus 5FU plus cisplatin for 6 cycles. Let me remind you here, 6 cycles followed by cetuximab maintenance versus cetuximab with cisplatin and docetaxel Q3 weekly with growth factor supports for only 4 cycles followed by cetuximab maintenance. And they were able to show us that this regimen actually had similar overall response rate as compared to the extreme regimen with with not significant, I mean, the rate of progressive disease was also similar, and the median OS was also quite similar of 14.5 versus 13.4 months. So let me ask you, are we comfortable using this cisplatin plus 5FU backbone in our Indian patients for the treatment of first-line treatment of recurrent metastatic squamous cell carcinoma of the head and neck? We really need to ask all of us that, because if we are talking about the Keynote 48 trial and the approval of the use of this IO agent, as Dr. Talreja has already shown us this beautiful slide, the chemotherapy backbone was platinum plus 5FU. And in the summary keynote slide that was shown to us in ASCO, the first question that we need to ask us is for the symptomatic patient, you know, who is suffering from this cancer, is there an improvement in PFS and overall response rate achieved with giving this very expensive therapy as compared to the other arm? And the fact is that there was no benefit in objective response rate, no benefit in progression-free survival. And when we know that for the symptomatic patient, you have to get some response rate. If we look at only the pembro alone arm, you will see that there was progressive disease of more than 30% compared to 9% in the extreme arm. When we look at the combination, even in the combination, there was more progressive disease in the pembro plus chemo arm versus the extreme regimen. So we really have to be careful when we are selecting our patients. If your patient is asymptomatic, great. But how many of our patients with recurrent metastatic disease are asymptomatic is the question that we need to ask ourselves. Do the IO agents have the same impact, whether when we are looking at two different subsets, recurrent only versus metastatic disease? And the answer is that there is a difference. And in fact, in the recurrent only disease, there is really no difference between the IO plus chemo versus cetuximab plus chemo arm. And in this trial, 30% of the patients had recurrent only disease. And these are the patients who are usually symptomatic and they have life-threatening disease. They are the patients who will have, the blood vessel will get involved by the tumor and they will be bleeding out. And these are the patients who require rapid tumor shrinkage. And let's talk a little bit about sequencing. So before this Keynote 48 came out, we were all quite comfortable using first-line chemotherapy with cetuximab, followed by an immunotherapy, either nivolumab or pembrolizumab. And the vice versa, is that true? And I will come back to the slides that Dr. Talreja showed us about the use of EGFR agents in Keynote 48 in the second line. So this is a very nice slide. It was presented again at ASCO 2020, coming back again to that TP Extreme trial. And they showed us that a large number of patients did go on to get second-line therapy in both the arms, the extreme versus the TP Extreme arm, more than 65%. And IO was given to 16%, 17% in each of the arms. And when we have given TP first and followed it up by immunotherapy, our median OS is 21.9 months. And again, this is about the 7 or 8 months PFS that we talked about in the Keynote 48 for PFS too. And what about looking at sequencing in our Indian patients? Let's get real. All of us are giving weekly chemotherapy with paclitaxel and carboplatin. So what about sequencing in these patients? So this is again a very nice poster that was presented in ESMO Asia in 2020, where they gave patients upfront paclitaxel, carboplatin, and cetuximab weekly, and their overall response rates guaranteed, it was a small subset, it was 80%, the PFS was 7 months. Then they randomized these patients on progression to either nivo or oral metronomic chemotherapy. And let me show you that the median OS even in this group was about more than 20 months, 20.4 months. So again, sequencing could be the way to go in our patient population. And there is no OS data on the use of cetuximab or EGFR-based therapy after you have used IO. All that Dr. Talreja showed us was the PFS too. And in fact, I will point out that in this Keynote 48, only 40% in the patients who got pembro plus chemo went on to get second-line therapy. The number was higher in the cetuximab chemo arm, and only 18% of them in the pembro chemo got EGFR agents. We also have all heard about hyperprogression, and we know that hyperprogression is more common in the recurrent metastatic head and neck squamous cell carcinoma. In fact, it is between the ranges of 15 to 30%. So that's something that we really need to be careful about in our symptomatic patient. And let's again come back to the results of Keynote 48 in the different ethnicities, different populations. This is a poster, this is a poster from ESMO Asia, which showed us very clearly that the results are not the same when we look at the Asian group versus the non-Asian subset. There is a difference in the non-Asian subset between pembro plus chemo versus extreme, which is not there in our
Ma'am,
Asian
would request
population.
you to conclude your...
We know that cetuximab has data in all populations. My conclusion, therefore, is that every patient with recurrent metastatic squamous cell carcinoma of the head and neck is unique. And we really need to tailor our therapy based on the needs of our patient. Indian patients are way different than the ideal patients that we see in these clinical trials. Cetuximab plus chemotherapy has shown overall response rate and OS benefit across all patient populations. And with sequencing data, perhaps the way to go is cetuximab plus chemo followed by an IO, given that it can have an overall survival of more than 22 months. And we really need to realize that risk of hyperprogression is a distinct entity, it's a reality, and that OS results are not same for all populations, especially the Asian population. So really, sequencing by utilizing all the active agents will be more cost effective, and it will lead to a better overall survival improvement. Thank you very much.
Sir, you are muted. You need to unmute. Deepak Singla, sir. You are
Yeah,
muted.
I'm sorry. Thank you, Dr. Vikas, and thank you, Dr. Anubhav, for this wonderful debate. And definitely, we have to agree that our population is different, and we have to practical that what subset of population we are treating with. Now, move on to next session. I would like to invite Dr. Naresh Mani, sir, who is the Director of Oncology and Head of the Department of Medical Oncology at HCG Cancer Center, Jaipur, and preoperative immunotherapy in locally advanced head and neck cancer, present and future. Dr. Sumani, sir, over to you, sir.
Thanks. Thank you. Good evening. And thanks to the organizer. I was thinking that the IO has established itself in the first line relapse refractory setting. But after the impressive talk by Dr. Anubha, I am a little bit back now that should I really talk about the immune checkpoint inhibitor even in the neoadjuvant setting. So she really has given the jolt to me. But let me do my job a little bit. So my slides are visible to everyone?
Yes, sir. Yes, sir.
Yeah. So I have been assigned the talk of what's new coming in this field. That is the immune checkpoint inhibitor in the pre-operative setting in locally advanced head and neck cancer. So this particularly talk has the certain reasons to think for that. There are rationale for the neoadjuvant immune checkpoint inhibitor in the head and neck cancer based on the anatomical rationale advantage. There are certain disadvantages also. And let's discuss some clinical evidence presently available to us. Now, standard of the care, as we understand today, is that curative intent treatment is either surgery or post-op RT with or without chemo based on the risk factors, or radical dose RT with cisplatin, carboplatin, 5-FU, doublet chemo, or cetuximab. And nivolumab-based approach is another approach which we sometimes use in our Indian setup. And yes, in the larynx or hypopharynx, induction chemotherapy followed by the locoregional to prevent the organ preservation. This is the broad outline of the way the treatment is being done for the head and neck cancer. Now, rational to think for more why it is required, because the outcome for the locally advanced head and neck cancer patient remains poor, and we have the maximum number of the HPV negative patients with us. And immune checkpoint inhibitor has emerged as one of the pillars in the head neck cancer also, especially in the recurrent setting, as we just had the discussion. And with success in the first and second line in the relapsed metastatic setting, obviously they will be discussed more in the adjuvant setup, along with the concurrent RT, or in the neoadjuvant setup also with or without chemotherapy. That's we are going to see them. Data from the relapse refractory setting are obviously as single agent or in combination with the chemotherapy are quite impressive. They have established in that setting, and now that is setting the stage for their use in the curative setting in the neoadjuvant or neoadjuvant followed by adjuvant, or in the concurrent scenario. Now, they have been applied thoughtfully in the conjunction with the curative intent treatment, where the surgery is the mainstay of the treatment. Now, this immune checkpoint inhibitors application has given the thought to allow to revisit the potential role of the neoadjuvant chemotherapy as the part of the definitive treatment for the local head and neck cancer. We all know that neoadjuvant chemotherapy is applied only select group of the patient because that has not shown any survival gain so far. Now, practical aspects, the success of the neoadjuvant immunotherapy before surgery with or without adjuvant treatment offers the prospect of using the tumor for in situ anti-cancer vaccination. Because the whole tumor is there, so that becomes something like the vaccination before the definitive management or before the full tumor is taken out by the surgery. Now, data has demonstrated the potential applications in the neoadjuvant and perhaps in the adjuvant setting also. But as on today, enthusiasm for the concurrent RT and the immune checkpoint inhibitor has been tempered by the dismal outcome or by the no positive outcome. The further research needs to be focused on the definitive schedules, predictive and prognostic marker-based application, or the selection of the patient. Now, various predictive markers, the biomarker which we discussed across the various tumors for the immune checkpoint inhibitors are the same: PDL1, TMB, tumor infiltrating lymphocyte. But for the head neck cancer, smoking versus no smoking, HPV positive versus negativity, they all have been studied and attempted to correlate how to best select the patient for this particular scenario. Now, pros and cons of this are there, and we know that the tumor can be assessed easily, lymph nodes can be assessed easily, immunological, it's a immunological tumor, expression of that PDL1 is very high, and tumor can be, later on can be subjected for the curative aspect, and so on. But yes, with the neoadjuvant immune checkpoint inhibitors before surgery, there are certain cons also. The tumor may progress, there may be the hyperprogression, we may miss the curative approach also. So many things are there. And as on today, the definitive ways to assess the response, to assess the benefit of the immune checkpoint inhibitors, especially with the short duration of the immune checkpoint inhibitors, the immune mediator response criteria, they all have not been decided very clearly. Now, combining immune checkpoint inhibitor with the surgery in the locally advanced head and neck cancer, the potential benefits may be, as I just enumerated, that is that it may work like the anti-tumor immunity and the memory against the tumor-associated antigen before the en bloc removal, something like working as the vaccination. It may potentially downstage the tumor, that may lead to the more effective, less morbid surgery, favorable modification of the need of the adjuvant post-operative RT with or without the chemotherapy. So these are the potential benefits, and it may improve the local, regional, and the distant disease control with reduced treatment-related toxicity, which is a big concern. So in a nutshell, the various ways of applying the new adjuvant or neoadjuvant immune checkpoint inhibitor before surgery, concurrent CTRT in adjuvant setup, there are the different ways, and these all trials are ongoing. So this is a slide with little bit crowded slide, may not be so visible, but this slide particularly highlights the various clinical trials which are ongoing presently, phase 2 and phase 3 trials, how immunotherapy with or without chemotherapy or with radiotherapy before surgery is being applied. So I would like to highlight 2 or 3 trials. That is the primary endpoint of these early phase 1 and 2 trials basically included the safety in neoadjuvant setup, the pathological response, radiological regression. Now, important new thing which is in this particular thing is the pathological tumor response. That is the PTR0, where there is no or less than 10% response, versus PTR2, where more than 50% response is there. The other way may be like pathological CR, where there is no viable tumor, MPR less than 10% cells are there, or we may sometimes apply the RECIST criteria, which is related to the immune RECIST criteria, which may be insufficient, as most of the trials show that the immune checkpoint inhibitors are given for very short period of the trial, 1, 2, or at the most 3 cycles are being given. The selected ongoing trial which are in this particular field are, we can see, like I would like to mention the keynote 689 or IM walk 010 trial, or the IM star trial, or the REACH trial. They are basically revolving around the surgical aspects. So neoadjuvant immunoradiotherapy followed by surgery. Both radiotherapy and immune checkpoint inhibitors are being combined. The particular trial showed the 21 patient SBRT with or without nivolumab. The dose of the SBRT was again different: 24 gray 3 fractions or 40 gray 5 fractions over a period of 1 week. Then there was a gap. Then the surgery was done, and then the adjuvant nivo for the 3 months was given. This trial showed the impressive major pathological response to the tune of 86% and a complete pathological response 67%. That well tolerated. There was no delay in the surgery. So this sort of the trials need to be duplicated. Large randomized trials are needed to basically define that what is the outcome in this particular trial. Another trial which probably we all are becoming aware is the keynote 689 trial, phase 3 trial. It's a large trial of the 600 patients previously untreated, high risk, resectable, locally advanced cancer. The arm one is basically pembro as neoadjuvant, followed by surgery, and then standard of care adjuvant therapy, RT plus minus chemo, plus adjuvant pembro. The arm two is surgery, followed by standard of care adjuvant RT plus minus chemotherapy, depending on the risk factor. Now, the primary endpoint is the pathological response, event-free survival, and secondary endpoints are obviously overall survival, clinical partial response, and quality of life parameter. So the potential aspect of these sort of the trials may be the delay in the curative intent surgery in the locally advanced head neck cancer, which are suitable for the surgery. Tumor may progress, tumor may have the metastasis, hyperprogression may be there. This all may lead to the unfavorable consequences in this particular trial, sort of the scenario. So logically, it becomes that we combine the immune checkpoint inhibitors with the chemotherapy as the neoadjuvant before surgery. So this we know as on today that induction chemotherapy has the minimal survival gain before the definitive CTRT, but it has shown the substantial pathological response. But there are the concerns, limitations because of the survival gain. A longer neoadjuvant phase may be required if we really want to see the benefit of the immune checkpoint inhibitor, because the response rate remains the slower or lower. To maximize the proportion of the patient who may have the major pathological response, to improve the depth of the response, and possible delay in the curative treatment. So we need to really think of that how we can combine the immunotherapy with the chemotherapy in the neoadjuvant setup. So this sort of the combination should allow the more rapid and enhanced response. And we basically now have the experience in the metastatic setting or the relapsed refractory setting that yes, IO plus chemo can be combined. It's a safe and useful. The potential benefit may be the greater radiological response. This may allow for the less extensive and less morbid surgery, and it may lead to the potential disintensification of the adjuvant therapy in the patient who achieve the major pathological response or good partial response. So various trials of the immune checkpoint inhibitors with the chemotherapy has been also done in this, like neoadjuvant nivo combined with the weekly carbopacli, and this sort of the one trial of the semiplimab, another immune checkpoint inhibitor with the cetuximab, along with the chemotherapy is also being done. So it's reasonable to anticipate IO with the chemo because it's likely to reduce the extent of the surgery resection, modify the post of RT, and convert the unresectable locally advanced head neck cancer into resectable, and generate the anti-tumor memory T cells, potentially reduce the likelihood of the locoregional and the distant recurrence also. So what I want to highlight basically, more than a dozen trials are ongoing in this particular field. Neoadjuvant, single agent, or IO in combination do not delay the surgery. It seems safe. Most trials are using immune-related pathological response criteria. Despite lack of the consensus, neoadjuvant IO in head neck cancer may allow for the post-ICI treatment de-escalation. That's another potential. So I would like to conclude that neoadjuvant trials are endorsed by the strong biological and anatomical rationales available as on today. These rationales establish the head neck cancer as an ideal model for the study for the efficacy and safety in this particular field. Several neoadjuvant immunotherapy trials have been conducted which demonstrate that single agent or combination are safe and they do not they are not associated with the delay in the curative surgery in this particular field, which is very important. Notable pathological response are common in this particular, even with the short immune checkpoint inhibitors. Even one single dose of the IO are associated with a higher response rate and with the chemoimmunotherapy combination also. And in select populations such as the HPV-related oropharyngeal cancers, they have also demonstrated a very high response rate. While some studies have reported longer disease-free survival times, but definitely larger trials are needed to confirm these promising results. So finally, design of the future trials should be the biomarker guided in order to define the disease niche and the optimal therapeutic combination where the IO may be more effective in the neoadjuvant before surgery. Ultimately, to me, the future looks very bright as the IO as a part of the curative intent treatment. And definitely there is a cause for this optimism. With this, I would like to thank all of you once again. Thank you.
Yeah. Thank you, Dr. Somani, for... Hello. Thank you so much, sir, for this wonderful talk. And so I think it's time to conclude the session and over to the organizer, Rahul.
Yeah, thank you. Thank you, everyone, for joining. And thank you for the wonderful panel discussions and the presentation. I thank each one of you for sparing your time on Saturday night. And we all say good night. So good night, everyone. Thank you, everyone.